Good morning, everybody. On behalf of Digestive Cancers Europe, DiCE, I would like to warmly welcome you all to the 5th edition of the Colorectal Cancer Screening Summit. My name is Karen Coleman. I'm a journalist and a broadcaster from Ireland and a professional conference moderator, and it's my pleasure to be the moderator of this morning's event. It's great to see so many of you joining us today. You're all very, very welcome. Now, as you know, today's event is dedicated to sharing perspectives, experiences, and advancements in colorectal cancer screening programs across Europe. The theme of this year's summit is scaling up colorectal cancer screening in Europe, aiming for 90% coverage by 2025. I just want to run through one or two housekeeping issues before we formally get down to business. Unless you're a speaker or panelist, can you please ensure your phones are kept on silent and your videos are turned off? We will be having 3 panel discussions throughout this morning's summit. It would be great to get your questions for those discussions when we come to the questions and answers session. So please, can you submit your questions through the chat box on your Zoom platform? I'll be reminding you of these as we go along as well. So as you'll have seen from the agenda, it's very busy. Let's get started. And to open today's summit now, it's my pleasure to introduce our first speaker, Eric van Cutsem, Digestive Cancers Europe co-founder. Good morning, Eric. You're very welcome. I'm going to hand over to you now.
Good morning, Karen. Thanks for chairing this important summit. And indeed, also welcome again on the team of DiCE. So I'm professor of digestive oncology at the University of Leuven, and I'm one of the co-founders of DiCE, and actually I'm board member of DiCE. And DiCE has been very active, different aspects of GI cancers, digestive cancers. And one of the flagships and one of the important topics is screening. And today we're discussing on scaling up the screening for colon cancer. Because indeed, prevention and hence screening, because that's a secondary prevention, is still the best treatment today of colorectal cancer. We have made enormous progress in our knowledge on and our treatment options for patients with advanced disease, but the best is still there if we can achieve and make a diagnosis in early stages, or eventually, because of the adenoma carcinoma sequence, also prevent colorectal cancers. If you look in countries who have a good participation, there you see clearly that patients who have a colon cancer detected through a screening program, that the chance of having metastasis at the initial diagnosis is low. For instance, in Belgium, in Flanders, where we have a screening program with fictitious occult blood testing, the cancers who are diagnosed through a screening program, those patients have around 3% stage 4 at the moment of diagnosis. While patients who have their diagnosis based on symptoms, so not through screening, they have 20%, so 3 versus 20% chance of having a stage 4. And I don't have to convince you and to tell you that this is important for the outcome of patients. Patients in early stages, stage 1 and 2, have 80 or 90, more than 90% chances of 5-year survival, while patients in stage 4 have around 10 to 15% chances of 5-year survival. So screening is important. If we cannot prevent the cancer, we will at least see a staged migration. And therefore, it's crucial to make this successful that we have a good participation and a good coverage. And many countries have today in Europe a screening policy, a screening program for colon cancer. Some countries do it better. In other countries, still room for improvement. And especially if you look at the participation, there is a wide variation of participation. And one of the topics that we have to focus as DiCE also, and that we want to focus as DiCE, is to try to improve this participation, this coverage, and to make disappear this inequalities that we see through different populations and different countries. And cultural, social differences clearly influence that, but that's an important role on how to try to improve this. And moreover, there are clear challenges for the future also. We will have to discuss what is the optimal age. Today it's 50. Screening programs start at the age of 50. In the future, we have to open the discussion to see whether that will change or not. We have a sharp increase in many Western countries of early onset digestive cancers, including early onset colorectal cancer. DiCE organized a recent ENTRO meeting in Oporto a few weeks ago in collaboration with the European Commission on this topic, early onset colorectal cancer. This population screening will not solve this, but at least we should reflect and we should try to take some actions on how, so that we can understand better this early onset and to marriage, and to combine that also with screening policy in Europe. And then also another challenge is how we will involve in the future new screening modalities. That's not yet scaling up for high coverage, but that and high participation. But that may help in the future if in the future we can work with sensitive and specific blood tests, for instance. That's still a topic for research that's not implemented, but we have at least to try to understand that. And there also, I'm sure in the screening summit, some of the topics will be around this, the future options, future strategies, on top of trying to improve coverage and participation, as I mentioned. So that's what I wanted to say as setting the scene and why we are so motivated as physicians like myself, clinicians, researchers, to work on this screening and to do it the best way we can do it. Thank you for attending this summit. Happy to interact with everybody, and I'm looking forward to excellent speakers, faculty, and interactions. Thank you, Karen, and everybody for attending.
Thank you very much, Eric. And indeed, I think the points you make are very interesting and no doubt will be expanded upon during the next couple of hours. So thank you very much. And by the way, good morning to all those of you who may have joined us since we started just at the beginning of 9 o'clock. You're very welcome. I'm Karen Coleman, the moderator of the event. Well, now I'd like to welcome our next opening speaker. Lieve Wierink is the chair of the Board of Digestive Cancers in Europe, and Lieve was a member of the European Parliament for ALDE, the ALDE group, the Liberal Democrats group, until 2019. And during her time as an MEP, she was a member of the informal group MEPs Against Cancer and also the MEP interest group on the Patient Access Partnership. Lieve, good morning to you. You're very welcome. I'm going to hand over our virtual stage to you now.
Thank you very much, Karen. Good morning, everyone. I'm Lieve Wierink, so already said by Karen. Welcome to our 5th DiCE Colorectal Cancer Screening Summit. Today, we stand a critical juncture in our mission to transform colorectal cancer screening across Europe. Our ambitious goal is clear: achieving 90% screening coverage by 2025. This target is more than a number. It's about saving lives. Colorectal cancer remains a significant health challenge, yet we know early detection can dramatically improve survival rates. Our summit today is not just about discussing strategies, but about creating a concrete roadmap to widespread effective screening. Disparities across European countries are stark. While some regions have robust screening programs, others lag behind. These variations translate directly into differences in survival rates, health outcomes, and ultimately human lives. Our commitment must be to bridge these gaps, to ensure that geography does not determine one's chance of early cancer detection. We will hear today from experts who will share innovative approaches to personalized screening, policy advocacy, and community engagement. Each panel represents a critical piece of our comprehensive strategy, expanding access, tailoring interventions, and raising public awareness. As a survivor, I know firsthand the power of early detection. My personal journey drives our collective mission. We are not just healthcare professionals, researchers, or policymakers. We are advocates for every individual at risk of colorectal cancer. Our goal of 90% coverage is ambitious, but achievable. It requires collaboration across borders, disciplines, and sectors. It demands innovative technologies, patient-centered approaches, and unwavering commitment. Today, we take another crucial step in our journey. Together, we can transform colorectal cancer screening from a medical procedure to a life-saving public health strategy. Thank you, and let the discussions begin.
Thank you very much, Lieve, for that. Now, we will have a short video from our next speaker, and she is Marta Temedo, who is a member of the European Parliament from Portugal. Ms. Temedo is a member of the Group of Progressive Alliance of Socialists and Democrats in the Parliament, and she's with the Portuguese Socialist Party, and she has served as a Minister of Health in Portugal previously. So let's see that video now.
Ladies and gentlemen, it is a pleasure to share this moment with all of you. I want to acknowledge the importance of the 5th DiCE CRC Screening Summit and its role in addressing colorectal cancer in Europe. I want to thank Digestive Cancers Europe for organizing this event and for its commitment to patients. We are all aware that colorectal cancer is the second leading cause of cancer-related deaths in Europe, a preventable disease if caught early through screening. This is precisely why it is crucial to recognize the European Union's 2022 recommendation to achieve 19% screening coverage by 2025. This is an ambitious yet vital target. In the future ahead, we face key challenges: the need for equitable access to screening programs across all member states, the need to address disparities in healthcare infrastructure and resources between regions, the need for the reinforcement of public trust and participation in screening programs. But challenges also come with opportunities for progress. We need to advocate for collaboration across member states to harmonize policies and share best practices. We need to discuss the role of personalized approaches to screening, such as tailoring by individual risk factors. And we need to emphasize the critical role of public awareness campaigns in driving participation in screening programs. As policymakers, we also have a role to play in supporting funding, infrastructure, and frameworks to expand colorectal cancer screening access, in highlighting the importance of involving patient organizations and citizens in shaping and promoting programs. I take this opportunity to urge attendees to use this summit as an opportunity to identify actionable steps for achieving the 19% coverage target. I want to stress the importance of collective action in overcoming challenges and saving lives. So thank you to all the participants for their dedication and contributions to advancing colorectal cancer screening. I want to encourage your continued collaboration to build a better health for all Europeans.
And thank you very much. And that was Marta Temedo, who is a member of the European Parliament. Now, we are scheduled to hear from another MEP, Tomislav Sokol, and if we get Mr. Sokol up on the line, we will go back to him. But let's just go straight now to our first panel discussion, because obviously our opening speakers have mentioned the importance of screening and all the issues and the challenges associated with reaching the 90% target. So the theme of our first panel discussion is on policy and advocacy, expanding access and shaping the future of screening. Now, we're going to begin with an opening presentation from our first speaker, and then we will have a panel discussion with our additional 3 guests. It would be great to get your questions during the question and answer segment, which will follow their opening addresses. So please keep a note of your questions, put them through the chat box, and we'll try to get as many of them as possible, and the chat box through Zoom, by the way. So now let me introduce our speakers for this session. Our opening speaker is Iris Lansdorp-Vogler, professor at the Department of Public Health of the Erasmus Medical Center, Rotterdam in the Netherlands. And our 3 panelists are Urška Evanus, Director of the Slovenian National Cervical Cancer Screening Program and Head of Department for Cancer Screening at the Institute of Oncology in Ljubljana in Slovenia. We're also joined by Marsa Saleha, Professor of Medicine at the Faculty of Medicine and Director of the Institute of Clinical and Preventive Medicine at the University of Latvia. And our final guest for this segment is Agnieszka Kinsker-Ovans Kainen, and forgive me if I am butchering some of your surnames, but some of them are a little bit more challenging than others. But Agnieszka is a scientific officer at the European Commission's Joint Research Centre within the Directorate for Health and Food. Now, we will first, though, begin with our opening speaker, Iris Lansdorp-Vogler. And Professor Lansdorp-Vogler is going to deliver a presentation on the current status of screening programs across Europe, the key challenges in achieving this goal, and the policy changes needed at both EU and member state levels. Iris, a very good morning to you. You're very welcome. I'm going to hand over to you now.
Thank you so much, Karen, and thank you all for being here and asking me to kick off this very important panel discussion. So we're going to talk about expanding access and shaping the future of cancer screening. And I would like to start with raising a question on what we mean with access. If we look at Europe's Beating Cancer Plan, where the statement of the 90% coverage comes from, then their flagship number 4 in that Beating Cancer Plan on screening is that the Beating Cancer Plan will put forward a new EU-supported cancer screening scheme to help member states ensure that 90% of the EU population who qualify for breast, cervical, and colorectal cancer screening are offered screening by 2025. But if we think about what does an offer to screening mean, I would like to look at programs that report, and this is according to the latest cancer screening report in the European Union, the highest coverage by invitation, so the highest offer of screening for colorectal cancer. And this is, these are Wallonia and Brussels, in which 98% of the population is being offered colorectal cancer screening, Croatia, 100%, France, 99%, and the UK with 100%. But if we then look at the actual people being screened in these countries and these regions, there's actually a stark difference. In Wallonia and Brussels, only 6.5% at that time were screened by the test. In Croatia, this was only 15%. In France, it was 26.5%. And actually only the UK of those 4 countries reached at that moment a level that exceeded the 50% that is desirable according to the EU guidelines. So clearly, offering screening is not enough, and so there should be more. And actually, we know what more needs to be done. And what more needs to be done is having an organized screening program. And this example, although it's not from colorectal cancer, but for cervical cancer from Slovenia, shows very clearly why we need an organized program. Because what you see here is the cervical cancer incidence over the years in Slovenia. And you see that with the introduction of opportunistic screening in the 1960s, there was a decreasing trend in cervical cancer incidence, but until that lasted approximately until the 90s. And then after the 90s, what we saw is that cervical cancer incidence was increasing again. And it was not until Slovenia actually implemented a nationally based, organized cervical cancer screening program that they really saw an additional benefit of screening happening again. So really, you need organized screening to improve the access and quality of a program. What makes an organized screening program so different from just having an offer of screening? Well, for that, I think we need to go back and look at what defines an organized screening program. And actually, there has been a very nice paper done by the International Agency on Research for Cancer, IARC, where they asked an international expert panel what they thought were the essential and desirable criteria for an organized cancer screening program. And they came up with a list of 16 essential criteria. And if you look at that list, actually, the offer of screening is only one of the 16 essential criteria. And that's the first one, saying that you have a target population screening interval screening test. So basically, that's what the offer constitutes. But then there's a long additional list. And if we look at, I'm not going to go through all 16, but active invitation is important. Program governance is important. System for notification and recall, making sure people come back. But maybe most of all, and very widely, is the quality assurance. And quality assurance, I took in the broadest sense of the word. You need an IT system so you can measure quality indicators. You need to have training. You need to monitor. You need to evaluate your program. All of these aspects are very important. And that is when you have a better access to your program. So, fortunately, Europe's Beating Cancer Plan did not just say something about having a 90% offer of screening. They also recognize the importance of quality, because the second part of flagship number 4 was that the scheme will be supported by EU funding and focus on making improvements in 3 key areas. So that was access, but quality and diagnostics. And there's actually 2 EU initiatives that follow that Beating Cancer Plan that want to increase access and quality of cancer screening. And the first one is the European Commission Initiatives on Cancer, and there's one specifically dedicated to colorectal cancer, the ECICC. And then there is a joint action called EU Can Screen. I'm going to say a little bit more about both initiatives. So the European Commission Initiative on Colorectal Cancer, or ECICC, and I've put in the website and a QR code to get more information on this, is funded and coordinated by the European Commission's Joint Research Center. And actually, we'll hear more about this from Agnieszka later on in the panel. And the aim of this scheme is to improve the quality of cancer prevention, screening, and care, and contribute to reducing inequalities in accessing cancer services across Europe. And basically, the scope is twofold. On the one hand, the idea is to develop evidence-based guidelines on cancer prevention, screening, and diagnosis. And you see that on the left-hand part of this slide in the yellow-orange square. And a very important aspect of this initiative, of these guidelines, is that it's going to focus on organized cancer screening programs. But on top of that, and what is very interesting, for the entire pathway, so not just the prevention, screening, and diagnosis, but also the care pathway, there will be a quality assurance scheme developed. And as part of that quality assurance scheme, cancer care institutes, cancer screening institutes, can apply for accreditation, for European accreditation. And you can only get accreditation if you ensure that you cover the entire process of what you're supposed to cover. So the whole idea behind this is that you keep people in the system and that you make sure that the system takes care of it all along the way. So this is a very important step, this accreditation, towards going from just saying, okay, I'm offering my population screening towards saying, I'm offering my population screening according to how Europe wants it to be done, because see, I am accredited. The second initiative is also very important. This is a joint action in which the overall goal is to reduce the burden of cancer in Europe through effective, and maybe this is the most important word, and sustainable cancer screening programs. This EU Can Screen has several specific objectives, but what I want to highlight here is that it's not just about implementing screening, but it's about implementing quality assured screening for breast, cervical, and colorectal cancer, but also for the new cancers. And what is very unique about this project is that we want to ensure proper program governance and sustainability. And actually, Urška Ivanas is one of the founders of this particular part of the EU Can Screen, where we also want to build capacity for governance and sustainability of the programs by training the future generation of leaders. So that's going to be very important. So capacity building is the other thing that I want to highlight. But maybe even more important than that is bringing the community together. This is a huge project with representatives of almost all EU member states. And not just researchers, not just policymakers, but a mix of policymakers, a mix of researchers, a mix of program coordinators. And they're all being brought together in the same room, talking to each other, and we all want to try and improve the cancer screening programs. That said, if we look at, for example, an example in the Netherlands, where we have done a very good job at organizing our colorectal cancer screening program, and we actually meet all of those 16 criteria that were identified by the IR consensus statement, there are still issues. Because this is what the pattern of participation looks like in the Netherlands for colorectal cancer screening. And you clearly see that we have a very high participation rate to start with. We started with more than 70%. But what we also see is that since 2018, especially for first round screenings, there is a clear dip, and now we are no longer reaching the 60% participation with our first screening round. So having an organized program is a prerequisite, but you need to continuously try and improve it and are responsible for doing that. And one important aspect of that is disparities. And I've highlighted here migration background, but this is the same picture you can see for example, for socioeconomic status. We see that there's a huge difference in participation in colorectal cancer screening between the top bar, which is the Dutch heritage individuals, that almost reach 75% participation, whereas the Moroccan immigrants not even reach 45% participation. So there's a 30% point difference in participation between some of the groups in the Netherlands. And the Moroccan community and Turkish community are actually substantial groups within our population. So this is not a small proportion of the population that we're talking about. And that is, I think, another important aspect. If you have an organized program, you've organized everything very well, and you ensure that you have equal access for everybody. But equal access is not the same as equitable access. So equitable access means that you identify and you tailor everything according to what is necessary. So my proposal is to put forward a new EU-supported cancer screening scheme to help member states ensure that 90% of the population is not offered screening, but that 90% of the population at least is covered by an organized, quality-assured screening program, and that in these programs there is special emphasis on ensuring equity and access, because one size does not fit all. And with that, I want to thank you very much for your attention.
Thank you very much, Iris. Very, very interesting presentation and points made and your recommendations at the end. Please do submit questions through the chat box if you have questions for Iris on her presentation. I believe actually that our MEP, Tomislav Sokol, has joined us. We may go to Mr. Sokol if you're there. Good morning to you, Mr. Sokol. Are you out there online, and can you see and hear us?
Good morning. I hope that you can hear me and see me.
Yes, we can. I'm just going to introduce you because I didn't introduce you earlier. You weren't online, but just to let our guests know who you are, Tomislav Sokol is a member of the European Parliament from the Croatian HDZ party. He's part of the Parliament's European People's Party, and he is the EPP coordinator in the Parliament's Committee on Public Health. He's also the main rapporteur for the European Health Data Space and the EPP Shadow Rapporteur for pharmaceutical legislation. We will continue with the panel discussion after Tomislav Sokol has made his introductory remarks. So, Mr. Sokol, you're very welcome. It looks like you're in the Parliament. Are you in the Parliament in Brussels? Is that where you're joining us from?
Yes, I'm in Brussels. So thank you very much for inviting me. I have to apologize for being a bit late, but you know that it's pretty hectic now in the Parliament and also in Brussels. And I have to apologize that I will have to leave shortly after I finish my introduction. But what I wanted to say is that I thank you for inviting me. I think this is a very important event that you are making a reference to one of a very well-known types of cancers, colorectal cancer, and I think this is also the opportunity to highlight what we are doing on the EU level to tackle cancer in general, but colorectal cancer as well. As you know, EU has limited competences in healthcare, so EU cannot impose different health policies upon the member states. We cannot harmonize health policies as well and define what is covered, for instance, by health insurance. However, by supporting member states, by providing recommendations which are non-binding but still definitely represent a strong guideline for health policies of the member states, but also by providing financial help, by providing administrative help in organizing different programs and different projects like colorectal cancer screening. I think that we can still do a lot in helping member states tackle cancer. As you know, EU has made a big leap forward in terms of health policy by developing Europe's Beating Cancer Plan several years ago. This was the first systematic plan on the EU level, which covered all phases of battle against cancer, including research, prevention, early detection, which includes obviously screening, treatment, and afterlife of cancer survivors. This is what is also important is that this plan has contained concrete objectives, concrete goals, concrete benchmarks to determine whether things are being implemented in the right way, but also concrete funding, which is, I think, the most important. So here, obviously, as you know, research has become cancer research has become one of the priorities of the EU. Cancer research is now one of the priority missions of the Horizon program, which means more EU funding from EU budget for programs, for research programs and projects related to cancer, so much more funding than it was available up until now. We also have a lot of provisions on prevention, but also on early detection and screening as well. So early detection and screening is extremely important, because if it is done quickly, if it is done in the right moment, it definitely can improve health outcomes and save many lives. For instance, I come from Croatia, a country where our health outcomes in relation to cancer are not very good comparatively with other member states, and one of the main reasons is late detection of many types of cancers. So I think when we speak about early detection, about screening, this is one of the most cost-effective and one of the most effective types of health policies, and this is something that you will definitely support. So this goal of reaching 90% coverage of colorectal screening is one of the very important objectives. As I said, this is recommendation, so it's not legally binding, but EU can definitely provide support and help member states in reaching this. When we speak about cancer and about cancer treatment as well, EU has provided a lot of important things in the Europe's Beating Cancer Plan. For instance, the creation of networks of centers of excellence across member states, and which are being developed now, which I think is also extremely important. And in the end, when we speak about the afterlife of cancer survivors, here the most important initiative is the so-called right to be forgotten, which means that we want to prevent by way of legislation patient discrimination of cancer survivors, because it is often the case that cancer survivors suffer discrimination, that they have to pay higher insurance premiums, and this is something which we cannot tolerate on EU level, and this is something that needs to be prohibited. We've done progress. So I was also the shadow rapporteur of the EPP, of the largest political group in the parliament, on Consumer Credits Directive, where we introduced the right to be forgotten. But now the plan is to introduce it in other pieces of EU legislation as well. In addition to Europe's Beating Cancer Plan, I would also highlight the initiative that you already mentioned. That's the European Health Data Space. European Health Data Space is a binding legislation, and this will create a real breakthrough in terms of how we use health data. So it is divided in so-called primary use of data and secondary use of data. So the idea of this is that all of our health data is gathered in electronic health records in a common European format, common European standard. This will be made available to every patient via an app. The patients will decide whether they want to share this data with their medical professionals. And the idea is that when patients go to a doctor, when to go to another hospital, to another member state, that doctors there will be able to access all of their health data right away, which means that they will not have to repeat testing, diagnostics, etc., etc. So the idea is that the diagnosis can be made and treatment prescribed in a much faster way, without overlaps, without doubling things, etc., which I think is also extremely important for individual patients. Secondary use is crucial in terms of research. So the idea is that all the data sets which are now not being used to an optimal extent, which are present in hospitals, in research institutes, etc., are systematized, structured. These catalogs will be made publicly available, and those who want to do research, for instance, on digestive cancers, can and see that there's a data set which can be useful for them, let's say in Germany, can make a request to access this data set through to a German health data access body, a public body, and then if this is authorized, they will be able to access the data in a secured environment, data in an anonymized or pseudonymized form. So the idea is that we make available for research much more data than we have now. And I think for medical professionals, for academics, for everybody who is trying to do research, who is developing new medicines, etc., this will be a real breakthrough. So I think also for cancer patients, this will provide a lot of opportunities also to develop new treatments, innovative treatments for cancers as well. Personalized medicine, like personalized screening, is also very important. So this is an area where definitely we can make a lot of progress. So all of these initiatives in terms of supporting research, in terms of making battle against cancer one of the priority missions of Horizon, by making the data available for research from across EU through this European Health Data Space. So all of these initiatives, I believe, will make it possible to develop new and innovative treatments, screening methods, including personalized screening, help many cancer patients on the EU level. The last thing that I want to mention, which I think is important, is now we are fighting for the EU health budget. This will be the most important battle, because we need to implement all of these programs on EU level. Now we'll start negotiating next year the next 7-year budget, and here getting it right, so getting enough money so that we can implement all of these initiatives like European Health Data Space will be of utmost importance. So my plea to you and to all the stakeholders who are active like you, who are engaged, who organize different activities, etc., is to really also put pressure on the national governments and other politicians to make it possible for us to have a really strong, health, robust EU budget, so that we can really make a difference on the EU level, so that you can continue to support national policies and to continue leading the battle against cancer. So thank you very much. I hope I wasn't too long, but I think that it was important to mention these initiatives. Thank you again for inviting me, for being proactive and organizing these kinds of events, raising awareness, which I think is very important. And I can also promise to you that I will continue to be an advocate for cancer patients and continue to do whatever I can to promote this topic in the level of the European Parliament. So thank you.
Thank you very much, Mr. Sokol. And just before you go, actually, now we're not going to have time to put questions to you, but just to say there was a question about whether you'd be open to support EU projects promoting quality assurance in Croatia. And if so, would you find the time to talk to NGOs in Croatia dealing with it? So you might follow up on that a little bit later. And also, DiCE, the DiCE member organization in Croatia, would like to be in contact with you. So I think the DiCE organization will actually connect you with that, if that's okay with you. Thank you.
No problem. I will be glad. Thank you.
Brilliant. Okay. Thank you so much, Mr. Sokol. Very good. And thank you for joining us this morning. Now, we're going to continue with our panel discussion. We heard from Iris earlier, those opening remarks. The panel is about policy and advocacy, expanding access and shaping the future of screening. We have 3 panelists now who are each going to give a couple of minutes overview on certain topics. And indeed, Tomislav Sokol mentioned the EU aspect of all of this, and that's very relevant for our next speaker. She is Urška Ivanus, Director of the Slovenian National Cervical Cancer Screening Program and Head of Department for Cancer Screening at the Institute of Oncology in Ljubljana in Slovenia. Urška is going to talk about EU legislation and national compliance, ensuring sustainability and reinforcing screening program governance. Urška, you're very welcome. Good morning to you. I'm going to hand over to you now.
Thank you, Karen, and good morning, everybody, from a sunny but very cold morning in Slovenia. We have managed to implement all 2 recommended cancer screening programs in an organized population-based approach: cervical in 2003, breast in 2008, and colorectal in 2009. All 3 programs are reaching high screening examination coverage and high quality of health services, from screening, triage, diagnostic, treatment, and follow-up after treatment. And that's why they're already yielding the results at population level in terms of lowering the burden of cancers. It was not easy to come as far as we came, and often countries are approaching us. These are mostly countries from Eastern Europe. If they could come if we could share our experience, how did we succeed with implementing those 3 cancer screening programs? And in the last 2 years, we are sharing our experience as an open days of Slovenian cancer screening programs. And in the first year, we had 30 participants. In the second, already 70. So what I would like to share with you today is what we are discussing at those meetings and what did we actually learn so far. So first of all, we do screening because we want to save lives. For that, we need to reach high coverage by the screening test, high quality of services, and we all do face problems with disparities. We want to lower them as much as possible, but this is really difficult. However, screening also do harm due to overtreatment and overdiagnosis. We cannot avoid that. And this harm is done at the level of the individual that is invited to screen, and at the level of the healthcare system, capacities including, and the state, the health budget. Because we are inviting clearly a really large number of people to screening in order to detect early and treat pre-cancer or cancer in just a few, we really need to be sure that we are doing more good than harm. And that it's not, because of that, it's not surprising that already in 1968, Wilson and Jungner have written the principles for cancer screening that should be met in order that we are sure that we are really doing in practice more benefits than harms, and that we are doing screening in cost-efficient way. In Europe, in 2003, first EU Council recommendations were adopted for cancer screening, recommended organized population-based screening in Europe for 3 cancers: cervical, colorectal, and breast. Due to the initiative of European Beating Cancer Plan, these recommendations were revised in 2022, where there were changes suggested to the already 3 existing screening and already previously recommended screening programs, but also there was a recommendation for a careful approach to a stepwise implementation of the 3 new screening programs via the pilots: lung, prostate, and in some regions also gastric. And that had put a new challenge in front of all European countries, those who have already managed to implement the already old screening programs in a way that they are sustainable, that they are yielding results at population level, but also those who still struggle. And those countries now have 6 cancer sites that they can choose from. How to prioritize and how to overcome the barriers that have already prevented them to implement the recommended cancer screening programs in the past. So why do we have these implementation challenges? It's not a problem. We mostly know what we need to do. The problem is how to transfer that into practice. How to implement such a complex structure as a cancer screening program is, as Iris showed in our introductory lecture, to another complex system as health system is. And it's not easy to transfer all the benefits and harms and cost effectiveness that we have reached in the control trials where the environment is really controlled and transfer it into the healthcare system when the environment is not controlled. In practice, many things can go wrong. And we are going to address that within the EU Cancer Screening project, as it was already mentioned. We are going to, for the first time ever, we are going to try to define what are the determinants and what is the framework for the sustainability of cancer screening. We are going to develop European guidelines how to assess and address barriers and tools that will help countries to do that. We are going to upgrade the CANCON governance model and develop governance structures like more general, but also country specific for some countries involved in the program. We're going to develop framework for prioritization in cancer screening, but we are also going to do already some exercise in some countries. And we want to build a peer support network across the countries that would help cancer screening programs to improve their implementation and outcomes. We have learned the hard way in Slovenia that only knowing what to do is not enough. We had decades of opportunistic screening, as Iris already showed, and then the incidence of cervical cancer went up. We have learned that widespread health services are not enough. You need governance, you need quality assurance, and everything that comes with that. So we have done a very good job with cervical cancer screening. Now we are facing very similar problem with prostate cancer screening. So if there will be time later in the discussion, I can elaborate about that a little bit more. But let me just finish my short speech with words that I'm really looking forward to our, I would say, to the future of cancer screening in Europe. I think we have a very good we have done a lot, and together within the EU Cancer Screening, also within like gathering like today, we are really going to reach the target of we are going to do the good job. Thank you.
Okay, Urška, thank you very much. I've no doubt you are going to do a good job. And hopefully we will get an opportunity to expand on some of the points you mentioned there. Now, Urška, stay with us. And Iris, you're with us as well, of course, because we are going to get into questions and answers after our next two speakers have given their just very brief opening remarks. If you could keep them to 4 minutes, that would be great, because that gives us more time then to take questions from the audience. By the way, we have a question and answer box on the Zoom platform. Some of you have been putting in your questions already. Please do submit the questions, because it would be great to get a sense of what are the issues you would like to ask our panelists about. But now let me introduce our next panelist. Marcis Leha is a professor of medicine at the Faculty of Medicine and director of the Institute of Clinical and Preventive Medicine at the University of Latvia. Professor Leha is a consulting gastroenterologist at the Digestive Diseases Centre in Riga, Latvia, and he will discuss CRC screening programs in Latvia. Professor Leha, you're very welcome, and I'm going to hand over to you now. And just if you wouldn't mind, keep your opening remarks to 4 minutes. Thank you.
Thank you, and congratulations with the success of this event. And yes, indeed, what you have heard already from the previous presentations is the indication of discrepancies, disparities, and not always reaching equity between the different countries in Europe, between different population groups, socioeconomic groups as well. And it's a bit sad that after the presentation of the success, what has been reported by Iris and Urshka as well on what are the programs and how the programs are really reaching all the criteria of organized screening, I have to illustrate maybe with another example. That is a possibility to improve and to grow the program. And just to illustrate how it is in Latvia, the decision was made, and that was already a long time ago made, to go for colorectal cancer screening through GPs. So GPs are motivated by certain financial incentive really to invite the participants, the eligible target group, to participate in the screening. And from that point, we can say that the invitation coverage is 100% because everybody is eligible to receive the screening test. On the other hand, the real situation is completely different, because about 1/5 of the GPs have not even requested the tests from the laboratory, meaning that 1/5 of the population do not have the access to screening at all. Even if requesting the test to the GPs, they will not get. The other proportion is then, what is the proportion of individuals that are attending GPs on a regular interval? And definitely that is not 100% as it was anticipated. So coverage could be estimated at 100%, organized invitation at 0 because nobody is invited in an organized way, active invitation, no ideas because we do not know what is the proportion GPs are inviting, and the participation rate actually is around 25% as for now, not reaching the minimal criteria. Then coming to the next step, to the quality assurance, and there once more, we are facing problems with the data platform, with the indicators to be reported to the data platform. And as a result, we do not have the control over the delivery of the tests and invitations. We can say that we have pretty well control of quality in the laboratory part because that is one centralized laboratory. And then when it's coming to referrals to endoscopy, follow-up reminders, so we are once more back to really poor results because we cannot really follow this up. And not speaking about the treatment that we believe is really qualitative, but the quality indicators are not really reported. So from that point, and that is actually, it has been mentioned a couple of times already, what is ongoing within 2 ongoing projects, namely ECIS and UCAN Screen, and you will hear more on the UCAN Screen project further on. I think those aspects of managing organized screening, training the leadership and the capacities, as well as issues on the data platform. And therefore, this will be addressing inequities. The big question is how the countries will uptake this. And I think that is another important aspect for DiCE really to address. Thank you.
Thank you very much, Marcis. And no doubt, again, people will have questions for you. Please submit them through the question and answer box on your Zoom platform. Now, our final panelist is Agnieszka Kinsner-Ovaskainen. Agnieszka is a scientific officer at the European Commission's Joint Research Centre within the Directorate for health and food. And she is going to talk about promoting quality of the screening process, the role of EU Commission initiatives for developing quality assurance schemes and guidelines. Agnieszka, you're very welcome. I'm going to hand over to you now.
Thank you very much, and I hope you can hear me well. So good morning, everybody. And yes, well, I think we have heard already quite a lot that the European Commission as such is very well aware about the need for organized population-based screening programs, and also considering, of course, different target groups, infrastructures in the different countries to be successful. This is not new. As Urszka said already, the Council recommended organized population-based screening programs to be implemented in the member states already in 2003. This was further reinforced now in 2022 by the new updated Council recommendation. And in fact, it was also recognized both by the Parliament and by the Council that to be successful for the implementation of these member states, the Commission should help member states and encourage to implement, or let's say to develop, evidence-based guidelines accompanied by quality assurance schemes for this organized population-based screening program. And I think this is the role that we have taken up at the GRC in collaboration with DG Santé by establishing the Commission initiatives on cancer. The whole story started basically in 2015 with the first initiative on breast cancer, which is now going on for several years and has issued more than 70 recommendations. And I have to say a very successful recent development is the validation of the quality assurance scheme, which is now being available for rollout. And the Commission is planning for this rollout in the coming months. This is followed, of course, by the colorectal cancer initiative that started in 2022, and recently also the cervical cancer initiative in 2024, and this is done in collaboration with IARC, with the International Agency for Research for Cancer. And soon we are planning to extend the same efforts, so establish Commission initiatives on the 3 other cancer sites which were addressed by the recent Council recommendations, so prostate, lung, and gastric. Just very briefly to say, what are the objectives of the cancer initiatives? Of course, one of them is to help meeting the timelines, but not only. In particular, we are really focusing here on enhancing the quality of care, on trying to improve by these guidelines screening coverage in the sense of giving the correct guideline to the member states, and also overcoming inequities in accessing quality ensured care across Europe, which do exist, and I think everybody recognizes this. So with these initiatives, we are targeting in particular countries where these needs are the highest, where the services and programs maybe are not yet available or not yet as well established, and where coverage is low. And of course, the focus, and I want to stress this, of the initiatives is on organized population-based screening programs. And the focus is also on the European context. So whatever we are developing should be fit for Europe. So of course, the outcome of the initiatives are on one side, the guidelines and the quality assurance scheme. They can be either directly implementable, or they can also be adapted to the local context, to the local settings, depending on the needs of the countries. Maybe it's important to stress also that the methodology for development is really scientific evidence-based. It's a transparent process. It's an independent process. So we are working with a multidisciplinary panel of experts, and which includes, of course, epidemiologists, program managers, but also clinicians, and very importantly, patients, because the whole system is patient-centered. And the methodology is reproducible, it's internationally recognized, and the evidence which is gathered via mostly systematic reviews is great, taking into account is assessed taking into account the great decision program framework, which takes into consideration, of course, the priority of the problem, but also all the issues that have been discussed by the previous panelists. So the desirable and the undesirable effects of a screening program, whether there is uncertainty about the variability in how much people value the outcomes, so people values are important, but also the resources used, so the costs, but not only financial resources, also the availability of healthcare, for example, staff, of infrastructure. Acceptability by key stakeholders is an important aspect as well, which at the end of the day will result in better or worse uptake of a program. The feasibility, finally, and equity. Equity is really addressed here, and I think this refers to the question of to what Iris has been discussing in the beginning. Equity is an important aspect of the guidelines. So at the moment where we have issued, the ECICC has issued 17 recommendations on primary prevention and screening, and also 4 good practice statements for healthy lifestyles, and the first set of requirements for the colorectal cancer services. And of course, we are continuing to work in the coming months and years to address other recommendations on screening and diagnosis, including also risk stratified approach for colorectal cancer screening, and develop requirements for the whole care pathway. So this is in a very brief nutshell, but of course we are open to discuss it in the discussion during the panel. Thank you.
Okay, Agnieszka, thank you very much for that. Now, let's make sure that all of our 4 guests are on screen. So Iris, Urszka, Marcis, and Agnieszka. Yes, very lovely. You're all there. That's great. We've about 15 minutes or so for questions. I want to go to the ones that have been posed already from our viewers watching us online this morning. I don't know whether any one of you can answer the first one, but let me put it to you and let's see. It's from Christopher Vella. Will there ever be an official stance on preventative medications like aspirin while the CAPP study is still ongoing? Does anybody want to answer that question? Oh, yes, Iris, yes, thank you.
Yes, this is actually one of the questions that is being addressed by the European Commission Initiative on Colorectal Cancer. So there has been done a formal evidence review, and now we're processing the information, and the recommendation will be issued based on the available evidence between the benefits and harms. So yes, there will be, I'm not sure we're going to call it official stand, but there will be this topic will be addressed in the European Commission Initiative on colorectal cancer, and it's also a question that was addressed in the European Code Against Cancer.
Okay, thank you for that, Iris. And we have another one, Urszka. This is specifically for you. You mentioned peer support groups as part of the implementation process. May you please elaborate on the role and responsibilities of these groups? That question coming from Sandra Palais. So Urszka, maybe you could address that question. Thank you.
Yes, thank you very much. And I need to clarify that what I meant with peer support was peer support of stakeholders that are engaged within the countries, the European countries, that would collaborate and help each other across the borders. It's like the peer support that patients organizations are offering to their members. We as screening coordinators, as the researchers, also our policymakers, sometimes feel that we would benefit if there would be a little bit more formal connection that would connect us from all these stakeholders from different countries to discuss, let's say, the procurement methods that we are using in our countries. We are very good in collaboration regarding the research questions about what to do, but we are not collaborating a lot on how we do it. And we hope that during the EUCAN Screen project, we will manage to assess the need and then to shape the structures that will sustain and will enable all the stakeholders to network also on the question how to do it.
Okay, thank you for that. Urszka, we have a question in here from Colm O'Moran. Should GPs be involved in screening programs? Now, Marcus, you talked about GPs already. Do you want to address that question? You're muted, actually. Would you mind? Yeah.
I'm happy to address this, absolutely. I think we know that it is benefit to have GPs involved. The question is to what extent and in this way. No doubt that they have to be informed at least, and they should be supporting the programs. So definitely there's benefit for this, even if sending invitation letters that are signed by GPs, but in organized matters that would be beneficial. On the other hand, we cannot really rely purely on GPs. If we want to go through GPs, yes, GPs could be the first stage of invitation, and that could be working in some countries. But then in the case, if this is not successful, then anyhow centralized program should uptake and follow up those that are not participating. And just to mention, it is more expensive. If countries want to go this way, if they have extra money to pay to GPs and for organized program, definitely that is doable. In particular, if the population is really well attending the GP offices, but otherwise it might be more rational to have the invitations surpassing GPs, but having GPs informed, educating, and definitely supporting the program. Thank you.
But can I just ask you to develop that a little bit more, Marcus? So somebody may be concerned, they may have symptoms of a colorectal cancer. Is the first point of call not the GP? I mean, who would they go to then if the GP is not going to be the first person they go to see if they may get on a screening or may have a screening test?
I believe this will be absolutely the minority that when entering the screening age, the next day will go to GPs and ask for a test. I don't think there will be too many, but they could get the invitation from the organized screening system platform on the first day they are becoming at the age or they are eligible for screening. On the other hand, if they are concerned, if they have symptoms, if they have family history, definitely then they are attending GPs at any age before the age of the screening, probably. And then definitely the GP should know and should further refer the patient for evaluation, but this will not be within the screening system usually.
Okay, let me ask you another question, Iris. And it was very interesting, your opening presentation talking about inequities and everything, and we might talk further on that. But do you think the EU should be more specific about the targets it sets for cancer screening?
Yes, I'm worried that if we make the targets like we've set them now, that 90% of the population should be offered a screening, that's too easy. If you simply put in place a reimbursement for everybody to be screened between age 50 and 75 for colorectal cancer, you already exceed that requirement, even if nobody takes up the test. And therefore, I was really proposing that we should, and my proposal was maybe 90% should be covered by organized screening program, or we could set a target for participation in a screening program. And I realize that we're balancing here because there's always the balance between the desirability, what we like to achieve, and the feasibility. If you put the bar too high, people will maybe not try to climb over that bar anymore. But if you put the bar too low, and I think that's where we are right now with the target, everybody can climb it, and it's really not a target. And I think what my presentation showed, but I think also what the other panelists have clearly said, is that the offer of screening is not enough. And especially we know that with organized program, when we're talking about equity, organized programs are much more equitable than non-organized programs. Because what you see with an offer of screening without an organization is the healthy aware are the ones that get screened and often get over-screened. Whereas the people that maybe need it most do not know where to find the screening and they won't go. So that would be and I would love to hear the other panelists' view on that.
Okay, hands up, just press the yellow hand there if you want to comment. Any of our other panelists on this? Agnieszka, Urska, Marcis? Okay, maybe you'll... Marcis.
While I'm trying to find the hand, just to echo...
Just put up your hand like this.
What Iris has been mentioning, indeed, in the situation of Latvia, everybody is offered in principle, but really the minority is really benefiting of this. So indeed, that is too little what we do have in the Europe's Beating Cancer Plan.
Okay. Agnieszka, and I'm going to go back to you as well, Urska. In your presentation there, you talked about, I think it was 17 recommendations that the ECICC is making. Can you give us a little bit more detail about, you know, those recommendations or the questions being addressed in those recommendations?
Okay, of course. So as I said, the ECICC has started working in 2022. So, and the whole work is quite heavy in the sense that everything is based on rigorous systematic reviews, looking at the evidence in detail. At the moment, the recommendations that have been issued were addressing whether at all colorectal cancer screening should be done in asymptomatic adults, which are aged between 50 and 69. We have issued also some good practice statements on healthy lifestyles in colorectal cancer primary prevention, and this is addressing alcohol consumption, smoking, physical activity. The group worked also on screening age ranges, so really looking at within which age ranges it should be recommended, that it should be implemented, and also at which frequency the tests should be done. So all of this will be addressed. These are now being finalized, the recommendations. They are not still yet available online, but they are in preparation to be published. So this will be available. And recently also a big set of recommendations on the invitation strategies for colorectal screening programs. And as Iris mentioned as well, the use of aspirin and other non-steroidal inflammatory drugs was addressed. And for this, we are also going to publish soon the recommendations. So these issues are addressed. What I wanted to say also is that all of the recommendations are not put there in stone. They will be regularly updated as there is new evidence coming. So this is not something like, you know, once and for all. We are going to go back to this as time passes. The next topics that will be addressed by the working group is also issues which are related to the part of screening, but as well diagnosis. So the bowel preparation, management of polyps which have been detected, issues also related to artificial intelligence, genetic counseling and staging. So really going more in depth into the practical aspects. I don't know if Iris wants to add something more to this because she's also a member of the working group. So maybe you want to add something to that.
Iris, would you like to add something to that?
Yes, this is all very good. One aspect that you hadn't mentioned yet, Agnieszka, and which is very relevant to this topic, that we're also looking at invitation strategies. So that specifically, we're looking at the question that was raised before, the role of the GP. We're looking at including the test or not. So those would be very important. And for those, we specifically also look at what they might do for equity. So that's, again, something that hopefully there will be more specific guidelines later, now that we're working on this, where it's not just screening from 50 to 75 or whatever the age range will be eventually, but it also says, well, and you should invite this way, and you should use that test, or those kind of things, I think would be very helpful.
Okay, I just want to quickly touch on a couple of questions that have come in from our viewers online. This one is specifically for you, Marcis, from Barbara and Mark Moss. They say pharmacies in the UK could step in to support screening. They are generally happy to do this in the UK. Would you think this is a good way forward, as they generally know their local people better than many GPs?
Yeah, thanks. I think it could be different options for delivering and collecting the tests, and that has been illustrated with examples from Italy, where really, at least in some parts of the country, the tests are being delivered and collected back through pharmacies. That could be an option. Of course, it depends once more on the costs, whether the pharmacies are not charging, whether it is not more expensive to the program than being mailed. That could be probably the most rational option, but definitely that could be a possibility, mainly because in the case to assure the proper delivery of the tests, because it has to be delivered back in certain time frame, and if you cannot manage this, in particular in hot temperatures, through ordinary mail, in this case pharmacies really could be an option. Another option could be maybe laboratory, different regional facilities as well. This definitely could vary from country to country, but I think this is not replacing anyhow centralized invitation system. So whether the test is going with the invitation or not, that is already a secondary issue.
Okay, maybe just for a final question to you, Urska, because you talked about other screening programs that were poor in Slovenia and then have improved. So cervical cancer, for example, was the second most common cancer in Slovenian women in the past. Today, though, the incidence is low, and amazingly, you're aiming to eliminate cervical cancer. How are you succeeding in doing that?
Thank you. It was actually what Iris said before. We were doing quite a lot of screening in a small, I would say, in a selected group of more educated women who were at less risk. Women were satisfied, gynecologists were satisfied, we were thinking we were doing a good job, but actually the incidence went up. And it was not up to the point that we have decided to implement all these elements of organized screening that we have managed to decrease the incidence. And what was actually very interesting was that we did not change the screening test. We did prolong the screening interval. We did say the age limits for the screening. Before we switched to organized screening, 1/3 of our women were referred back due to pathological results in screening. In organized setting, only 5%. So we have put much less burden on women and in health system. And today, we are detecting and treating much more pre-cancers than we did before. And that's the power of organized screening and have good quality control. And today, of course, we are bringing 74% of women in the age group every 3 years and 86 every 5 years.
Okay, very interesting and very good work. Thank you for that, Urska. And that brings us actually to the end of this panel discussion. We're going to take a quick break, but I want to say a big thanks to Iris, to Agnieszka, to Urska, to Marcis for giving us their views and time. Thank you very much. Thank you for your questions. Please keep putting them in. The earlier you put them in, then the more time we will have during the question and answer session to go through them. So we're going to take a quick break. We're only 3 minutes behind schedule, which is brilliant. So can I ask you to be back here in 10 minutes? We're going to keep the line open. All you have to do really is just go maybe grab a cup of tea and coffee, and then in 10 minutes time, so it's now 10:18, so 10 minutes from 10:18 we'll open the floor with our second panel discussion, which is on personalised screening, tailoring interventions to risk. So see you very shortly after the break.
Each cancer group has its own needs and particularities. Therefore, it's of incredible value that the digestive cancer patients have an organization that looks at all of the major needs these patients have.
DiCE, on the other hand, does the heavy lifting to represent the patient voice in organizations governments, companies on national and European levels.
The message is, you are not alone. We are there when you need us.
For us, patients, the help is not only pragmatical with information or guidance, but also emotionally by feeling supported, heard, and understood.
Firstly, it's a network of colleagues and friends. We all work for common cause. Our countries are different, but many challenges are the same. DiCE and its network are an excellent forum for sharing information, benchmarking, and peer support in this work. In addition, this international collaboration has also brought good tools and knowledge to our everyday work with patients.
To be part of DiCE is very important as a physician. It gives you extra flavors and interaction and strategic thinking, how you can work together with patients.
The digestive cancer patient pathway is not yet standardized in Romania. So along with patients and medical specialists, and based on my 9 years of experience as a patient navigator, we are developing a cancer navigator web platform for colorectal, breast, and lung cancer. Our association is still providing navigation services for digestive cancer patients, but also for their carers, thus trying to optimize their pathway through the Romanian and European medical systems.
We recently launched a new strategy with a laser focus on improving early diagnosis for people affected by bowel cancer. We want to see 7 out of 10 people diagnosed at stage 1 and 2 in the UK by 2028. We're developing a targeted awareness roadshow, raising awareness of symptoms in people and locations with the poorest outcomes and the lowest engagement in the bowel cancer screening programme.
Joint decision making is really a hot topic in the Netherlands. Last year we participated in a redesign of a high-quality online tool that helps non-operable stage 4 patients to discuss treatment options with the doctors, including the important question of quality of life versus quantity of life.
As the CEO of DiCE, I take immense pride in leading a team of 9 dedicated and capable individuals. Together, we strive to advance the mission of DiCE, ensuring that our efforts positively impact the lives of those affected by digestive cancers, as well as raise awareness among European citizens on the importance of prevention, screening, and early diagnosis.
I admire the tenacity of patient representatives in work they are doing, despite the hard conditions they often experience themselves. And it's a real and worthy treasure, I think, and I wish all of them to remain the strength to hold on to that tenacity just as tenaciously and never lose the enthusiasm to do this hard but very valuable work.
We have to make DiCE stronger by attracting even more member organizations. We must ensure the best treatment for every patient, raise awareness among European citizens on the importance of prevention, and ultimately save for more lives.
We are DiCE! Woo!
Welcome back, everybody. It's time now for our second panel session, which is on personalised screening, tailoring interventions to risk. It's the same format as the previous session. We'll begin with an opening presentation and we'll follow with a panel discussion. And then, of course, as we did for the first one, it would be great to get your questions. Please do put them in through the Q&A box on your Zoom platform. And by the way, for those of you who may only be joining us now or joined us towards the end of the last session, you're very welcome. It's great to have you on board for this summit. My name is Karen Coleman. I'm a journalist and a broadcaster from Ireland, and I'm the moderator of this session. Now, let me introduce our opening presenter and our panelists for this session. So our opening presenter is Carlo Sonore from the Piedmont Region Cancer Prevention Center at University Hospital Città della Salute e della Scienza in Italy. Carlo has had extensive experience in public health, particularly related to cancer screening programs. And our panelists are Monica Furlich, Head of Department of Internal Medicine with Gastroenterology and Geriatrics in Klinik Floridsdorf in Vienna and Medical University Vienna, Austria. We're also joined by David Weller from the University of Edinburgh in Scotland. And our final panelist is Paolo Gheorghi Rossi, Director of the Complex Structure for Epidemiology and Risk Communication Service with the Reggio Emilia Local Health Authority in Italy. You're all very welcome. And I'm going to go to you first, Carlo Sonore, to give us your opening presentation, which is the transition from one-size-fits-all screening guidelines to personalised, risk-based approaches that incorporate genetic, lifestyle and age-related factors. You're very welcome. Over to you.
Thank you for the invitation. It's a pleasure to be here. I try to share the presentation. Okay, presentation mode. Thanks a lot. Well, we are considering to introduce a risk-tailored approach because we aim to target intervention of those who can benefit most. It is increasing benefit to those who are at higher risk of disease and reducing harm in subjects with low risk. We are already using stratified approach in different phases of the screening process. For example, people undergoing polypectomy within the following a positive screening test are recommended to undergo surveillance with colonoscopy if they have a high risk for getting the colorectal cancer in the follow-up, while low-risk patients are recommended to undergo a regular FIT screening. But the challenge is now to move from the one-size-fits-all approach that we are adopting in primary screening with all people in the target age and being recommended to undergo the same protocol to a risk-stratified approach. And we have two approaches for stratifying the target population based on their risk. We can use the estimate of an individual's a priori probability of getting the disease over a certain time interval, take into account age, sex, genetic susceptibility profile, family history, and level of exposure to modify the environment risk factor. Or we can use the estimated level of risk being detected within a pleasure based on individual screening history. We know that there are differences in background risk. For example, age analysis of age and sex-specific colorectal cancer incidence and mortality in several countries found that women mainly reach equivalent level of colorectal cancer cumulative incidence when they are 4 to 8 years older than men. In the programs, in ongoing programs, we already observed that the neoplasia yield is about 2 times higher among men than among women, and also men show a higher positivity rate and the screening test when using FIT-based approach, and the same positivity rate can be achieved when using different cutoff levels for screening. And in fact, there have been countries introducing sex-specific protocols in Finland and Sweden that has been used different positivity cutoff for men and women, while in Germany the starting age for screening was postponed to age 55 for women. In Finland and Germany, the program is now again offering the same protocol for both men and women, while in Sweden they are going on with a different cutoff for men and women. These strategies associated with a slight increase in the cost of the program. There is a slight increase in the detection rate of cancer and advanced adenomas among women, and a slight decrease of sensitivity of the test among men. When considering genetic susceptibility, we know that family history is an important risk factor for cancer, and it will be discussed further in the panel. But more recently, polygenic risk scores, which are calculated combining the risk of large panels of single nucleotide mutation, are also used to stratify risk. However, modeling studies are suggesting the risk-stratified screening based on polygenic risk is associated with an increase in the cost per person examined. They could represent a cost-effective approach if these models, these prediction could be more precise, that they could discriminate better between high and low risk, if the price of the test could be reduced, which might happen in the future, and also if this adoption of this approach could be associated with a substantial increase in uptake. We all know that lifestyle is associated with the determinant of cancer risk, and in fact, we can stratify people based on their lifestyle. What is interesting is the recent analysis of large case control studies in Germany, in Europe, which aim to estimate the 30-year absolute risk of developing colorectal cancer, accounting for genetic susceptibility and lifestyle, is that the increased adherence to a healthy lifestyle resulted in a lower 30 years absolute risk of colorectal cancer within any polygenic risk categories, and also both among men and among women. So healthy lifestyle can, to some extent, contrast the genetic susceptibility at some point. There are now the suggestion to use a predictive model also to derive a recommendation for screening. A recent guideline suggested to use a risk calculator considering age, sex, ethnicity, BMI, smoking status, medical and family history to calculate individuals' risk of getting a cancer over the next 15 years, and then using this result to recommend whether to start or not screening. And the strategies considered were FIT, every single year or every 2 years, sigmoidoscopy or colonoscopy once in the lifetime. And the recommendation was, in fact, a weak recommendation against starting screening for people with a risk of colorectal cancer over the next 15 years below 3%, and the weak recommendation in favor of starting screening for people with a colorectal cancer risk over the following 15 years above 3%. Of course, this kind of approach has also limitation. It implicitly favors shorter-term reduction in cancer mortality over longer-term decreases in cancer incidence. And in general, the feasibility of using background risk stratification in the context of ongoing program is still limited. There are pilot studies ongoing to assess different issues, and these issues are related to the acceptability for the target population and for the organizational impact of having an extensive addition data collection, which is required to stratify people based on background risk from different factors. There is also the problem of the discriminative accuracy of the models, the ability of the model to distinguish between low and high risk people is still limited at individual level, and misclassification of risk can result in inappropriate recommendation. And there's also the potential for stigmatization and discrimination, as the risk is often based on the evaluation on the assessment of individuals' lifestyle, which can result in blaming the individuals for their unhealthy lifestyle. So there are other options that are based on screen history, and these include also participation pattern and fecal hemoglobin level. As far as participation patterns are concerned, we in the context of the ongoing Italian screening programs, we observed that the cumulative colorectal cancer incidence over the 3 years following age 69, which is the stopping age of screening in most regions in Italy, was twice as high as among people who had not been screened between age 64 and 69, as compared to those who had at least one negative screening during the same period. So when extended the screening age range to up to 70 to 74, people without any prior screening should be probably prioritized for invitation. Also, a study analyzing the result of the fall screening round in 3 programs in Italy and in the Netherlands, based on previous participation, could observe that fit positivity rate was twice as high, and that the detection rate of advanced neoplasia was 3 times higher among those who never attended before as compared to regular attenders. But we have also now some promising results from studies considering the possibility to use prior fecal hemoglobin values among people with negative fit test results to stratify risk. Studies considering the result of 2 consecutive negative fit tests over 2 4-year follow-up and combining the result of these 2 tests are showing that the cumulative detection rate of advanced neoplasia and interval cancer rate over 36 months are 15 to 20 times higher among screenings with cumulative fecal hemoglobin level above the positivity threshold, within the case was 20 microgram of feces per gram, 20 microgram of hemoglobin per gram of feces, as compared to screenings with cumulative fecal hemoglobin level below the detectability level of the instrument. There is one of the advantages of these approaches. There is the need, no need for additional data collection, and also this approach might be more acceptable as there is a screening recommendation are linked, related to test result rather than individual characteristics. So in conclusion, having a risk-stratified approach is a complex endeavor, but because there is an increased organizational impact on ongoing programs, there are problems in ensuring informed decision-making, because there are several options, and there is the need to explain the concept of risk and why we are using different approaches. And again, the messages might become confusing, and people might get difficulties in understanding the rationale of the program, so the communication is important. And given this complexity, the potential for there is the potential for negative impact on participation. There are people who are referred for longer interval because they are at low risk and might not accept this approach, this recommendation. There is the risk of increasing disparities, given that we need more information for stratifying risk, and not all people might be able to provide this information. And that there is, as mentioned already, the issue of the risk of stigmatization when using health lifestyle as a risk stratification approach. But we have also some options for starting this, introducing this approach, and in particular, the utilization of prior fecal hemoglobin concentration is a promising approach, given its limited organizational impact. We don't need no additional information. All the information is already available within the ongoing IT system of the screening program. And there is a good discrimination of the approach. And there are 2 studies now. There's another one in UK, which is starting, one in the Netherlands and one in Italy, which are testing the impact of having different approaches based on the baseline risk defined by the screening history, and using different screening interval for different risk levels of participants in screening programs. And these studies are ongoing within established screening programs. But we have another option while waiting to find a way to use effectively the information about lifestyle. We can anyway use screening as an opportunity to promote healthy lifestyle, which represents a feasible and acceptable approach. And as you have seen in the European studies, the adoption of a healthy lifestyle can reduce overall risk independent of the genetic susceptibility. Thank you very much for your attention.
Thank you very much, Carlo. Very interesting. Thank you. And if you have questions for Carlo, please put them in to the Q&A box, and we will get to them. We will get to those questions during the question and answer session for our panel discussion. And speaking of our panel discussion, I would like to now invite our first panelist to make some opening remarks. She is Monica Furr-Leach, the Head of Department of Internal Medicine with Gastroenterology and Geriatrics in Klinik Floridsdorf in Vienna, and also Medical University Vienna in Austria. And Monica will talk on using family history and genetic predisposition to tailor screening. Monica, you're very welcome. I'll hand over to you now. Thank you.
Thank you, Karin, for this kind invitation. Thank you to all of you to giving me the possibility to be the part of this panel. We have many things to do. You have seen from, you have heard from Carlo Signore in his introduction that we have enough data of everything, but we need to simplify everything to our patients. The problem is we know just from the interventions, just from the observational studies that the patients with positive family history and with some genetics mutation has higher risk on colorectal cancer, but we need to simplify all criteria. You know, the Amsterdam criteria, which applies to patients with positive family, to find out the patients, on example, with Lynch syndrome. But we also know that our families are getting smaller and smaller, and we will probably not find out all the patients at risk, because we don't have such a big families as we had it previously. The second remark is regarding not only the patients with first-degree relatives and history of colorectal cancer, but also to the patients with polyps or advanced adenomas. If the sibling has polyps or advanced adenomas, they should undergo screening also before the age of 50. If the first-degree relative were younger than 50, but also if they are older, we need to tell them. So if the patients are younger than 50, we should ask for genetic syndromes. We should search for this. If we have children of patients with Lynch syndrome, we can ask to perform mutation in those children to find out if they are affected of Lynch syndrome or not, because the chance is just 50%, and they will not need to undergo yearly or colonoscopy or second-year colonoscopy. But we need to start awareness campaigns. We need campaigns. We need to tell the population that if there is a colorectal cancer in your family, within of your first-degree relatives, that your risk for cancer is double as high, and that you need undergo screening. And we also should not forget, within of tailoring screening the patients at higher risk of colorectal cancer beyond the family history and beyond genetics, which are the patients with inflammatory bowel disease, the patients with liver diseases like PSC, or simply fatty liver disease, which is also associated with double as high colorectal cancer risk. But we need to break it down to one simple recommendation and start to doing awareness campaigns. I don't think that we should wait for the results of randomized controlled trials, because they are very difficult to implement and very difficult to do. And we know that it takes years that the cancer develops, but we need to act now to recommend screening to those patients. Thank you.
Thank you very much, Monica, and I'm sure there will be questions for you as well, so stay with us for those. I'll move to our next panelist now. Welcome to David Weller from the University of Edinburgh. And just to give you some background on where David is coming from, his cancer research career began with PhD studies in Adelaide and Nottingham on bowel cancer screening. And then he later led the evaluation of the UK pilot of bowel cancer screening, which was from 2000 to 2003. And he's published extensively on roles for primary care in cancer screening, early diagnosis and survivorship. David is going to talk about incorporating lifestyle factors into personalised screening plans. Good morning to you, David. You're very welcome.
Thanks very much, Karen, and thanks for the invitation to speak at this really interesting meeting. So as Karen has said, I'm a general practitioner with an interest in cancer screening, and it's been really my lifelong interest to look at ways that primary care can improve uptake and other issues in cancer screening. So I've been asked to talk about lifestyle factors in stratified screening, and I guess a lot of our interest comes from modelling studies which suggest that there's, as Carlo has said, there's strong evidence that factors such as body mass index, consumption of red meat, low vegetables and dietary intake, alcohol and smoking can all increase the risk of colorectal cancer. So why not try and use that information to stratify our approaches? Of course, individually, each of those risk factors doesn't contribute a great deal, but if you put them all together, and particularly if you can combine them with other factors such as genetic information, as we've just heard from Monica, or previous screening history, or the current FIT score, these models can become quite powerful. And again, as Carlos said, collecting this information has the secondary benefit of creating opportunities for primary prevention. At the moment, screening programs in Europe generally just use age to identify the target population. We really need good risk prediction models, and there's more work ongoing with that. But as I said, there's a lot of interest now in trying to build these more complex models as a basis for stratification. If you look at the cost effectiveness modeling, most of these models, without taking all of the practicalities into account, do suggest that we could likely produce more reductions in mortality and reduce cancer incidence and save costs at the same time. But of course, translating those modelling studies into reality is the challenge that we're talking about today. But particularly, for example, in young people where the incidence might be lower, these modelling studies do suggest that taking the risk into account can be highly cost effective. Now, how acceptable is collecting lifestyle information? Of course, the general principle with cancer screening is to keep things very simple, and this, as Carlo has said, makes things more complex. We're asking for more information. We might be taking extra blood tests, and that could certainly put people off. And those who are identified at very low risk, they might get put off screening, or they might consider that they don't need ongoing screening. In the work that we've done, we've found sort of mixed acceptability, but on the whole, people seem to be in favour of their personal risk information being taken into account with certain caveats. How available, though, is lifestyle information? And it's quite difficult to get accurate information. There's all sorts of logistics that might involve. It might involve blood sampling. It might involve lifestyle questionnaires. It's tempting to try and use existing sources such as primary care, but in the UK, a lot of work has gone into that, and we've generally concluded that the quality of that lifestyle information is pretty variable, even for common risk factors such as smoking and alcohol. In Australia, in Melbourne, a group have looked at trying out risk prediction models in primary care, getting GPs to fill in a very simple sort of model, and that has been shown to have some impact on uptake. So on the whole, collection of lifestyle information, it's a big challenge and something we'll need to be thinking about. Finally, turning to some ethical issues, as already been mentioned, this does raise issues of privacy and confidentiality. Where is this risk management information going to be used? Could it fall into the wrong hands? Could it have an impact on equity? Is it fair on people who come out as low risk to offer them less screenings? In some qualitative work we've done in the UK, that has come out as an issue. And as we've already heard, what impact might it have on health inequalities? Do those people who don't have such good primary care records, for example, or who have less information about their genes, their lifestyle, whatever, do they face being further discriminated against and worsening the current inequalities in colorectal cancer screening uptake that we see in most countries around the world? So, as we've already heard, this remains a work in progress, but the fundamental underlying principle of trying to direct resource at those at higher risk, I think, remains the same. And in the UK, we're just beginning to pilot an approach where we're actually asking people for lifestyle information and also getting some genetic information, and doing that within the context of an organised screening program. That work, unfortunately, has just begun, so I don't have any results to share yet. But I think those sorts of pilots, testing the practicalities of using lifestyle information, will be very important going forward. Thanks.
Thank you very much, David. And again, if you have questions for David, and we are already getting some questions in through the Q&A box, please do submit them now so that we make sure we have enough time to handle some of those questions that you may have. But David, stay with us. Thank you very much. Very interesting points raised in your presentation. And now our final panelist at least, is Paolo Gheorghi Rossi. He is the director of the Complex Structure for Epidemiology and Risk Communication Service with Reggio Emilia Local Health Authority in Italy. And Paolo is a member of the European Commission initiatives on breast cancer, colorectal cancer and cervical cancer for the development of cancer screening guidelines in Europe. He's going to talk about the EU Can Screen joint action initiatives to favour piloting and implementation of risk-based screening. Paolo, you're very welcome. Good morning to you. I'll hand over to you.
Thank you very much for this invitation and for the opportunity to talk about the EU Can Screen joint action, which is coordinated by Latvia and in particular by Marcis Leia, that is here. So probably he can answer to some questions much better than me. This joint action is aimed at favoring the implementation of the European Council recommendation on screening, on cancer screening issued in December 22. This is a policy recommendation at the highest level of policy making in Europe. The Council, that is the joint of all the prime ministers of the member states, highlight the importance of applying risk-stratified screening when appropriate. And so the joint action consequently has a dedicated work package on risk stratification and screening. This joint action involves more than 100 institutions in 22 countries, and so you can imagine how large effort Marcis have to do and is doing great work on this. But the work package on risk stratification will look at the opportunities of tailoring screening for all the screenings, those that are consolidated, breast, cervical, and colorectal, and those that for which the Council made a recommendation for piloting new and a stepwise implementation in the next year, so lung, prostate, and gastric cancer. So the work package started with the definition of a general conceptual framework for risk-stratified screening. And this general framework is mostly that in screening, the benefits can only affect those that have the disease, while the harms usually affects all the people that undergo screening. So obviously, the higher the risk, the better the balance between desirable and undesirable effect. Obviously, we will work also on the ethical, legal, and social implication of applying this stratified screening. And the final output of the work package will be a toolbox for each cancer screening, in which we will have which are the possible strategies based on evidence, the tools for communication. This is a critical point, because communicating the risk may have desirable and undesirable effect on people who will receive this information and have to deal with this. And tools for risk stratification that can be complex model, including genetics or very simple variables, as for cervical cancer, being vaccinated or not, or the previous level of fecal hemoglobin, as Carlos presented. And then we should look at how the model, the protocol can be modified according to the risk, age to start, intervals, additional tests, or a different threshold for defining the positivity in some screening. And then the anticipated benefits from modeling and empirical evidence, and this will be will come from another work package that is a work package is exactly dedicated on modeling. And finally, what we need to monitor these new protocols. All this toolbox should be very practical for a way to help policymakers and public health decision makers in each member state to start implementation of risk-based stratification screening.
Thank you very much, Paolo. That's you finished, is it? Or did you have, you are,
yes,
brilliant. Okay.
4 minutes.
Oh, did you? No, you go ahead. Sorry, I thought you were finished.
No, it's okay, it's okay. I prepared a 4 minutes presentation.
Okay, so what were the final points you wanted to make? And then we'll go to the questions.
Sorry?
Oh, no, you are finished. Okay, yeah. Sorry. The joys of remote online conferencing. Okay, now that is brilliant. You all have made some very interesting points. So please, panelists, turn on all your cameras. Let's look at what questions have been coming in so far. We've got about 20 to 30 minutes or so for questions. Now, we did have one that's, it's come in from Natasha Antoliak, and I'll read it out in full. Croatia is participating in this joint action. In Croatia, we are now working on reorganization due to implementation change between GFOBT to FIT. On the other hand, our proposal of special half-organized programs for high-risk persons is accepted, and we work on preparations of prerequisites to start this program. That person will be sent to colonoscopy, not to FIT, according to indication. During this, I searched references for calculation risk, but there is no gold standard calculator. Is your opinion that any method of risk stratification has significant impact on long-term indicators, for example, survival mortality rates? Would anybody like to answer Natasha's question? And if you just raise your hand like that, if this is a question for any one of you, I'm not sure If there's anybody who feels they can answer that. I don't see any. Oh, yes, Carlo, yes.
No, just that, of course, a question that can be answered by also other panelists, and they can add, of course, I think. Well, the issue of starting the using calculators for of risk for orienting, let's say, the kind of approach to be used for screening is an open issue at the moment. In fact, there is not really probably a clear answer. There are several risk calculators that have been proposed. All of them have some, let's say, advantages and some disadvantages. One of the main disadvantages is usually that risk calculators are including age in the among the factors that are used for estimating the risk. And of course, as long as risk is increasing with age, they tend to privilege older people to start screening for older people. So that might be a problem in terms of prevention of the cancer. But yes, in principle, of course, we think that there will be an impact also on long-term outcomes like mortality rates when using a more, let's say, tailored approach to screening, because people who are at high risk might benefit from more intensive or screening or using more sensitive tests, like, for example, moving from FIT to colonoscopy. At the moment, we really don't know so much. It is important to go on with this pilot project to assess the intermediate outcomes of which are associated with the utilization of these risk calculators and the risk stratification. So that's something that at the moment should be piloted. It's important that several countries or programs are introducing or starting this pilot, because through the, let's say, comparative analysis of these results, it will be possible to go further and get more information about the potential impact also on long-term outcomes of these approaches. So the idea is probably to expand and extend and consolidate networks of activity on this pilot. The joint action will offer the opportunity for using these, for developing this kind of collaboration.
Okay, Carlo, thank you. I see Paolo and David both have their hands up. Maybe Paolo, to you first.
Thank you. Yes, I will try to answer to in part to this question. I think the gold standard for establishing how to what would be the best risk classification should be really created according to the natural history of the disease, and it must be screening specific for and for what we can achieve in this screening. For example, in colorectal cancer, we can reduce incidence. So incidence is the relevant endpoint more than mortality. And what is the time frame in which we can act on incidence? Which are the cancers that we are going to prevent, and what are the precursors of cancer that we can detect? So are they there in 5 years before, 10 years before? That's the time frame that we have to use, and this is also dependent on the test. So and I think this also has implication on how we frame or design the best studies to test the efficacy, because obviously there is a general statement that I said screening, risk stratified screening can be more efficient always, but if it can be also more effective, it depends if the actual intervals or of the screening tests that we have are optimized already for according to the natural history of the disease. If they are optimized, decreasing them probably will have a small impact on prevention. Increasing them will decrease the safety of the interval without having nothing more than less cost. And how to decide if we need a trial or not, it depends on on many factors, and this will be one of the output also of the joint action, trying to understand what is the best design and how we can best use the available information from empirical and model studies.
Thanks, Paolo. David, you have your hand up, and I see Monica. So, David, we'll go to you first.
My point is very brief. Just I think that's a great point to make about risk models, and we always need to be really clear about this the sort of time horizon that our risk estimate covers, because there's immediate risks and there are long-term risks, and some risk factors such as lifestyle can change over time. So somebody can go from having a high BMI to a very low one, or they can change their alcohol and smoking habits. So it's just one of the things to feed into the mix, that we do need to have risk models if we're going down this track that are adaptable and changeable over the life course, because otherwise people will get locked into a pattern of screening which may not be appropriate for their current circumstances.
Okay, thanks, David. Monica, you wanted to comment on this as well.
Yes, the problem is that we all know about the risks and everything, but we all think to complicate. We need to simplify. We should use one of those risk calculators and should set out the risk of colorectal cancer to 3%. But if we do this, we need to investigate it scientifically. So we need to do it only within of the studies. Otherwise, we will never get an answer if it's okay or if it's not okay, if we can reduce incidence or not. We need to stratify the patients and according to the risk factors, and use the risk calculator in one group and screen the other group with the same modality, and then to wait for 10 years. So that's the only how, for my opinion, how we can approach. So within of the pilot studies or something, or population-based screening studies. And the second remark is maybe we should more go to something which is more simple, like just a simple ultrasound of the liver, and if we see the fatty liver disease, to go for primary colonoscopy screening, and in other patients to go for FIT. I don't know. So there are many approaches, but we need to think simple. So we are thinking in models, and we know the data, and we know that we have to wait. But in this way, nobody will start. So we'll really start, and we need to convenient the countries to start something like this, to do it, of course, within of the quality assured programs, quality assured screening colonoscopies, and to do it within of scientific calculation, and not only within of the models.
Okay, thank you very much. We're getting a lot of questions in, so I'm going to try and get through them as much as possible now. Sarah Hook. Sarah, I hope that's the correct pronunciation of your second name. Sarah says, what if cutoff is already very low in organised screening programs? She gives examples of Flanders versus Netherlands there. How do we approach risk-based screening based on prior FHB? If no problems with colo capacity, better to keep low cutoff, or base it on previous screening result with higher cutoff, she asks. Colonoscopy is still the gold standard, so better to have more negative colonoscopies instead. I know there's a little bit of shorthand going on there. Who would like to maybe just one person answer Sarah's question, please? Yes, Carl.
Yes, I think that that's a good question, but the issue of using prior information about cutoff level, about the fecal hemoglobin level, is not directly related to the cutoff. The issue is to use cumulative information over several rounds to stratify risk based on the fact that people who are having consistently very low levels may not need could benefit from longer interval, while those who are who have hemoglobin level cumulative, which cumulative are over the positivity cutoff, can be referred immediately for colonoscopy eventually, or for short-term screening. So it can be used, the same approach can be used even when using different intervals. And within the joint action, we are in fact starting, the proposal came from Swiss colleagues from Switzerland, Kevin Selby, who is anyway will collaborate with the joint action as a parallel activity in a parallel country, the possibility to analyze the retrospective cohort from different programs to assess with different positivity cutoff and different eventually also screening interval, because there will be also colleagues from the US which might collaborate in this project, to assess in fact whether this approach of using prior information can be used or need to be modified when using different positivity cutoff in the different programs. So that's an open issue that's important. The idea is to minimize the potential harm for those who have a false positive result by using prior information to, let's say, tailor or to make the utilization of colonoscopy resources more efficient. Colo capacity is a problem everywhere, and so maybe it could be an approach also in terms of reducing harms and increasing efficiency.
Okay, does anybody else just want to briefly comment on that before we move to the next two questions? Anybody? I don't see any hands up. Okay, let's go to, I'm going to combine the next two questions, which are really, really relevant. So I'll read out both. And Anthony Rossi wants to know, is it time to start considering lowering the age for FIT screening from 50 years to 45 years? How can this affect colonoscopies in hospitals? And then Iga Ravitska more or less says, very similar question, more and more young people have CCR at a very young age, in their 30s or 40s or even younger. Isn't it high time to change the age limit of 50 plus of CCR screening? They are fit and healthy with no family history of CCR, but yet they get colorectal cancer. And I see, Monica, you have your hand up straight away there.
Yes, so we all know that it's probably the time, but we also need to think about the cost effectiveness. And before, so in Austria, we have lowered the age to 45 already because of the increase of colorectal cancer screening in the younger ages. But we still need to know that the risk is very, very low. The risk is very, very low. It's increasing. So for me, at the moment, the better approach would be to get the first degree relatives, to get the siblings of those patients who are affected in colorectal cancer screening at a younger age, to get probably these patients with unfavorable risk factors, who to endorse them to make a lifestyle change, that to lower the screening age to 30. So we need to find out the patients with genetic colorectal cancer syndromes, and we need to screen the families. If this young patient has colorectal cancer screening or also polyps, to find out all the patients with serrated polyposis syndrome, which is difficult to find out with FIT, so we will not reach them. And it's the same in patients with Lynch syndrome. We will find out the cancer, but we will not find the flat lesions which are not bleeding with FIT screening. So my approach would be to lower just a little bit to 45 and to ask the others for the family history and the other risk factors.
Okay, very good. David, you had your hand up, and I know Carla too. So David, to you first. Yeah, it's a great question. And in the UK, we have differing lower age limits, 60 in England, 50 in Scotland. Interestingly, England is moving towards lowering that to the age of 50. But as I suppose, as Monica says, the more you lower that age group, the worse the impact on the positive predictive value, and it becomes quite a sort of complex
complex of analysis. It does, I think, highlight the importance, though, of identifying individuals in those younger age groups at high risk somehow, however we can do that. And again, as Monica has said, identifying the family syndrome, such as Lynch, is critically important. But also, perhaps the landscape is changing, and we have a program in the UK called Our Future Health, and I think there may be other similar programs across Europe where, at a population level, people are providing information on genetics and lifestyle. We're getting polygenic risk scores really at scale now, and I think those sorts of initiatives, I mean, if we, over the next 5 years, move to a situation where we've got much better risk information without having to go to a huge amount of effort to get it, I think that is potentially a new era for finding younger people with colorectal cancer.
Okay, and Carlo, you wanted to comment on this as well, and we've got lots more questions. I'll try to get to the most of them before we finish in 10 minutes. Yes, Carlo.
Oh, just a short comment. There is the issue of the risk among young people, young age group, is a tricky question, because there is, of course, as already Monica mentioned, a very low absolute risk in these younger age ranges, and that the increase which was observed in some countries was not observed in all countries. So there is the need to have a context-specific evaluation of these of the approaches which can be adopted. Just to mention that in the European Commission initiative on colorectal cancer, in the working group, we are also considering let's say a recommendation about the lower age limit, in particular for fit screening, and that there will be some recommendation also on this topic, because that's important to address the way how to handle this problem. I think that in fact in younger ages, having paying attention to the possibility of identifying familiar syndrome, hereditary cancer is important, and also to promote a healthy lifestyle, because we know that probably the increase in the cancer incidence in this younger age group is probably related to the unhealthy lifestyle. That is definitely a component. So having primary prevention in this case, given also the very low absolute incidence, would be important.
Okay, Carlo, thank you for that. Now we've got an interesting question in from Simon Vanderberg. I am currently working on a knowledge graph of risk factors for CRC. Since it's such a complex disease, I have to restrain myself in order to not make a graph of the universe, so to speak. What is the threshold to decide whether a risk factor is relevant enough to include in a risk stratification model? Paolo, yes, thank you.
Yes, we had the same issue in the European Commission initiative on colorectal cancer. So when I saw this question, I immediately said, okay, that's really a universal problem. We used a threshold, I think it was 1.5 relative risk, just to be included in the possible. But I think it must be context specific. When you are talking about people that are already in a screening program, and so you already have a previous FIT test or a previous colonoscopy, the differences, what we know, are so strong determinants of the risk that any other small additional risk factor may give very few added value. If you are in a general population, you don't know nothing, you don't know any FIT result before, maybe information given by weaker risk factors is relevant. But once you have the first FIT or the second FIT or one colonoscopy, the information that you have for that patient is much more self-evident and deterministic than any other risk factor that you can collect.
Okay, Paolo, thank you for that. Let's go to Stephen Rowley's comment, and Monica, you certainly have been touching on this. One known risk in CRC is Lynch syndrome mutations. This can be a factor in several cancers. Does this change the picture? Is FIT relevant, or should we be adding MCED, multi-cancer early detection techniques, into the programs? Monica, do you want to start off with this?
Yes, I have seen this question just before, and I checked the current literature because we all have learned that colonoscopy is the best for Lynch syndrome. But during COVID, there were some initiatives to use FIT in Lynch syndrome patients. So it's possible. It's find out the patients with early cancer, but not with the flat lesions. And if we should use the other one, so for my opinion, we don't have enough data now. So for Lynch syndrome, I would always stick with the colonoscopy. But we from the ESG, we have recommendations for lowering the intensity of surveillance in Lynch syndrome patients according to the genetics, according to the mutation. Some of the mutation needs the colonoscopy only every 3 years. And as the quality of our colonoscopy and quality of our pictures and resolution increased as much, we are able to detect these early lesions in Lynch syndrome now and lower the risk of colorectal cancer of this patient, which we were not able to do this 20 years ago. But we are still learning how to. So I have no universal answer, but that's
yes. Okay. Does anybody else want to briefly comment on that? We have about 5 minutes left, and I want to maybe get to some others. Okay, I don't see any hands up. Let's go to Eva Kiratz's question. What is the capture of hereditary cancers tested in genetic counselling units in the UK and Austria compared to expected number of individuals? Now, who wants to answer that question? We don't have any hands up. Okay.
I'm not working with the genetic cancer syndrome, okay. So I
Eva,
just don't have this.
You'll have to get that answer from somebody else at a different stage. So we'll leave that. Let's go to Dimitri Amaxilati's question. Do we need to investigate further gut microbiota? Do you think it may give more information regarding risk factors? Is that microbiomes? Yes, Carlo.
Yeah, that's a good question. That's a topic which is under investigation. Again, it might be different if we use microbiome information with respect to among people who have a FIT positive test to improve the specificity of the positivity test result, or if we use this as a general test, let's say, as a primary screening test. There are studies ongoing trying to first of all, there are studies showing that there is an association with some microbiome signatures and the microbiome profile and the presence of advanced adenomas or cancer on a cross-sectional evaluation. We still don't know whether these changes in the microbiome profile are predictive of subsequent risk of cancer. And there are studies going on within ongoing screening programs that are addressing these questions. One interesting issue that we can use the leftover from the FIT tubes following the processing and the examination, evaluation of the level of fecal hemoglobin to study the microbiome profile. So this makes these studies much easier because you can collect a lot of material during within ongoing programs, and you have the prospective evaluation over several rounds. But these studies have just started, and these we will have some answers probably in the next years But this is really an interesting field of research at the moment.
I'm sure it is. And Monica, you also wanted to comment on that.
Yes, we should not forget that microbiome are the mirror of our lifestyle. If we change our diet, our microbiome will change within of the 2 weeks. So yes, the ongoing research is very important, but it's better to advise the poor persons to use the Mediterranean diet, to have healthy lifestyle, stay lean, and so lower the colorectal cancer risk.
Yeah, you packaged that up very nicely. Mediterranean diet, stay healthy, stay lean. And I like what you said there. The microbiome is the mirror of our lifestyle. Is that what you said? Yeah. Okay. Well, I think on that very interesting point, we leave this very fascinating panel discussion. A big thank you to our panelists, to Carlo, to Monica, to David, to Paolo. Thank you so much for your input and preparing your presentations. A big thanks to those of you who submitted questions for this panel discussion. Stay with us because we're just going to move on to the next one. But I'm going to say goodbye to our 4 panelists and we'll move on. It's our final hour. Goodbye to you all. You were brilliant. Thank you so much. You can, of course, stay on behind the scenes. You're very welcome. But this brings us to our final panel session, which is on public health and awareness, mobilising communities for early detection. Now, it's the same format as before. We're going to have an opening speaker who will sort of set the scene, and then we will have our panelists for their views, and then we're going to take your questions too. It was really brilliant to get your questions and really have the opportunity to put so many of them to our panelists. So please do continue to submit your questions. Now, let me introduce our opening speaker and our panelists. So our opening speaker is Isabel Mosquera Metcalf. Isabel is a scientist at the Early Detection, Prevention and Infections branch of the International Agency for Research on Cancer, based in France. Zorana Marovic is the CEO of Digestive Cancers Europe. Our next guest is Yasmin Hurst, Senior Research Fellow at the University of Central Lancashire in the UK. And our final panellist is Metka Glas from Europa Colon in Slovenia. You're all very welcome. And Isabel, I'm going to go to you first because you're going to set the scene, so to speak. You're going to talk about successful strategies for public health campaigns and advocacy to mobilise populations for screening. And I think you're also going to touch on the role of EU-wide public health initiatives in raising awareness. You're very welcome. I'm going to hand over to you now. Thank you.
Thank you. Share my screen. So thank you for the organizers for inviting me to this event, and thank you for the attendees. So I'm going to talk, as you know, about the communication and engagement to improve cancer early detection. And first of all, I'm going to touch a topic that has been already mentioned in the panel 1 on the barriers to cancer screening. So we see here several quotes of health providers and individuals on which are the barriers they face and which explains why there's a low participation to cancer screening. So we see, for example, in the top right, a health worker reporting, let's say, we have 2 health facilities that offer our service, but these do not have medical officers, and the available clinical officers do not have the capacity to screen. So they are pointing to the lack of enough trained personnel. But also individuals are reporting on the issues on availability of not having a nearby health facility that is offering the service, or that the time where the office of the hospital is open is not a good time for them. So issues on availability and accessibility. If we continue asking, we see also issues related to affordability. For example, getting screened is very expensive and is not a priority when I have my kids to feed or to pay for electricity. I will only get screened if I have a symptom or I have a surplus of money. Also issues related to understanding the language. We don't understand English that much. I did not do it because I don't quite understand. Or issues related to accessibility to get into the screening center. We do not have cars or a second car, and there's no public transportation in our area, so it is not as easy to go to see the doctor. Or having competing priorities. I've been busy with work and looking after the family. So these are issues related to availability, accessibility, affordability, but other issues that appear, and this has been also already mentioned previously, are acceptability barriers. So here you have a few examples. Nothing's wrong with me, so why should I do that screening test? If you go for screening and find out you have cancer, you might regret learning your status. What you don't know won't hurt you. Or, I have never heard of colorectal cancer screening. I was never recommended to do it, and nobody has ever told me it's available. Or I've heard it's physically unpleasant, or there's a lot of good remedies, good home remedies I can use. So these acceptability barriers point to an issue on awareness, and they are very much linked with health literacy. So what's health literacy? It's the capacity to obtain, process, and understand basic health information and services that are needed to make appropriate health decisions. And it includes 4 skills. Like the first of all is the ability to find, to seek information related to the healthcare system, that's disease prevention or health promotion. Then the ability to understand that information, then to evaluate it, to appraise it, and then actually to take a step further and apply it, use it to make a decision on how to proceed. And this is something, this process, this linkage between health literacy and decision making, something we need to take into account when we prepare communication strategy to speak with our stakeholders. Because we can think that population can be in any of these steps that you are seeing here. They can be unaware of screening, unengaged on participating or performing screening, undecided on this, deciding, participating or supporting it or providing screening in the case of a health professional, or actually undergoing screening. So we need to think where the population is, in which phase they is, to design the strategy in an appropriate manner. And when we do this, we have to have, obviously, a very clear objective and understand the positions of these stakeholders and how they would like to receive the information. It may be through mass media, through SMS, by letter. We need to understand this. And ideally, we should be involving stakeholders from the initiation of a program. This doesn't mean that if we have already a screening program that's already running, we shouldn't involve them now, because it's never led to involve stakeholders in the discussion on how to improve it. Traditionally, the relation with stakeholders has been from the screening program to inform the population. It's been a one-way direction communication. But more and more we are seeing now, we are moving towards a high engagement. So there's a consultation, so there's a two-way direction communication. They may be involved in identifying which are the barriers to screening, even collaborating in finding solutions till we get to have them empowered. So when we design the communication materials to approach the population, we need to think, we have to explain clearly which are the benefits and harms. We need to take into account which are the competing priorities that the population face and which are the existing barriers to be able to provide a solution for them. We need to use a contact point that users are familiar with. For example, it can be the primary healthcare providers. And we need to use, obviously, the language of the population so they can understand it. And this is in terms of the language itself, but also in the terms of the content. So it has to be presented in a simple language. So it's be able to be understandable by all literacy levels. And information should be provided in a tiered approach, so starting from basic concepts until building up to more complex information. When we deliver the information, we'll be thinking of different ways of distributing this. So nowadays, we think always of the digital media, but we also have to consider this population that is not doesn't have digital literacy, isn't like a very used to use internet. So we need to provide also printed materials, and we can't forget there's other ways of communicating with the population, like through mail, through mass media, or for example, we have direct communication with a healthcare professional. And then who would speak to the population? So here I brought you a couple of examples that we need to think who actually gets the population. So the first is an example from Romania on the cervical cancer screening program. So there they wanted to improve the screening among the target population, and they realized that one of the TB programs that was quite successful in the target group was one on traditional dances. And they approached the presenter of this program to be able to present these videos. And she agreed, and you see here on the left, it's her presenting this. And on the right, it's an example that's not related to screening, but I thought it'd be useful also to understand. In this case, it's Colombia. They wanted to approach a hard-to-reach area in Colombia that had very low vaccination rates for COVID, and they had also issues related to malaria and maternal lactation. So it's an area that they are very much fond of music and freestyle, rap, etc. So the WHO regional office decided to organize a competition for freestyle singers. And those that won were then trained on the healthy lifestyle messages. And then they went to that area to give this message through this leisure activity like this listening to music, right? So we need to think of who speaks to our audience. So these are two examples, and obviously, as you very well know in DiCE, is that people's lived experience is a very strong voice to be able to also use. And we need to understand that different people experience the disease in a different way. So we need to take into account the different voices when we actually discuss how to improve the screening programs or the cancer pathway. When I was telling you before the case of Colombia of training these freestyle singers, we need to give training to who is going to actually be sending this message. So there's in the Cancer Prevention Europe project, there's two modules that are available online, the European Code Against Cancer Recommendations, and also a training module on evidence and myths and controversies around the cancer screening and cancer risks. They are currently available in English, but I know that the European Code Against Cancer will be soon available in other languages. And here you can have the QR code if you want to scan it and then try to do this course, sorry. And then the European Code, related to this European Code Against Cancer, is a project that is looking at what I was telling you before, the channels you use to communicate with the audience. And so in this case, the BUMPA project is working on developing an app that can help introduce all these changes in behavior. So it monitors the behavior of the user, and depending on that behavior, they propose concrete actions to be able to reduce the cancer risk. So to summarize, you see, health literacy is a key topic, obviously, to communicate all cancer risks. But if we increase health literacy, we are transferring knowledge, and this way we are empowering the population. And it has been seen that when the population is empowered, we see an increase in cancer screening participation, an increase in the ability to recognize early symptoms of cancer, and obviously it contributes to advocacy, which you will know well in this group, DiCE group, and obviously in advocacy we can influence the change in policies. Thank you for your attention.
Thank you very much, Isabel. A very comprehensive rundown on what is possible and the campaigns out there. You're going to stay with us for the panel session, so thank you for that. So now we'll go to our first panelist for this session. Zorana Marovic is the CEO of Digestive Cancers Europe, and Zorana is going to talk about the role of patients' organisations in the development of EU guidelines and Q&A schemes. Zorana, you're very welcome. Good morning to you. I'll hand over to you now. Thank you.
Good morning, Karen. And I want to use the opportunity as the CEO of DiCE to thank all the panelists, but also all the participants for wonderful discussions. I have been really enjoying here and listening to all the discussions. So speaking about the patient involvement in development of guidelines and quality assurance schemes, I believe that relatively until recently, healthcare systems were not built around the voices of patients, but more around the voices of policymakers, clinicians, and researchers. And I think what is great is this paradigm is shifting, and it's shifting for the good reason. Patients and citizens are no longer seen as passive recipients of care, and they are observed more as partners, as experts in their lived experiences, as well as valuable contributors to shaping better healthcare systems. And when it comes to the involvement of patients in creating EU guidelines and quality assurance schemes, and I'm really proud to say that together with another patient advocate, I'm involved in the ECICC, the work of the ECICC working group. I see two transformative benefits. So the first one is relevance, as patients live through the realities of diseases, treatments, and care systems, and they highlight the gaps in treatment and care that experts might overlook, whether that's accessibility challenges, side effects, or psychological toll of certain procedure or of the disease. and therefore the insights of patients and citizens ensure that guidelines are not just scientifically robust, but are also practical and human. And then another important aspect is trust. When patients are involved in crafting the standards, those standards gain greater legitimacy, as it shows that healthcare isn't done to people, but developed with them, fostering trust and compliance. And I believe that patients' and citizens' involvement will have a profound impact in shaping the EU's colorectal cancer screening programs. And by integrating patient feedback into quality assurance schemes, we will ensure these programs not only emphasize accuracy, but also address concerns around privacy, communication of results, and the psychological safety of participants and many other aspects. However, involving patients and citizens does come with challenges. It requires commitment to training, resources, and mutual respect. And patients and citizens must be empowered to engage in a meaningful way and should be engaged through platforms where their voices are heard, not just as tokens, but as equals. And speaking about the development of EU guidelines and quality assurance schemes, the vision is clear, which is to embed patient involvement systematically across all stages of the guideline development, from the initial design to implementation evaluation. And this is not just an ethical imperative, but a practical one, as I have mentioned. And when patients are at the table, the end product is stronger, more comprehensive, and more aligned with real-world needs. So thank you, Karen. I hope that I have not exceeded my 4 minutes. Over to you.
Oh, no, you very much on time, Zorana, and thank you very much for summarizing the issues there. Thank you for that. Again, Zorana will be staying on for our panel discussion. So if you have questions for her, please do put them into the Q&A box. But now we're going to Yasmin Hurst, Senior Research Fellow at the University of Central Lancashire in the UK. And Yas is going to talk about collaborating with community organisations for targeting hard to reach populations. I think is it Yas or Yasmin Hurst, Yas, that you would like to?
Yas is fine, thank you.
Yas is fine. Okay, very good. So you're going to talk about, very interesting, how to collaborate with community organisations for targeting hard to reach populations, which I think reflects some of the points that were made earlier by some of our speakers. So very interested to hear your presentation. I'll hand over to you now. Thank you.
Thank you so much. Well, thank you. Firstly, thank you for having me today. I would like to start with a bit of a landscape of the screening participation in England. So as mentioned, that the screening age has been reduced to 50 to 74, and it's with the fecal immunochemical test kit since 2019. And with the introduction of the FIT kit, our uptake has increased from, as mentioned also earlier, from 50% to now 70%. While it has demonstrated the ceiling impact to 70%, we still have 20% differences between the most deprived and least deprived areas. And further evidence also suggests that we have disparities in ethnic minority groups, people who don't use English as their first language, people with learning disabilities, sensory impairments, and severe mental illnesses. And targeting these communities using community organisations is very important to address the inequalities. And I'll provide an example from northwest of England. In 2015, the National Health Service in Northwest commissioned this health promotion programme called Call for a Kit, with an attempt to improve screening uptake among GP practices with less than 60% uptake. And Call for a Kit is delivered as a person-centered, non-clinical health promotion programme, and the people who are delivering has this cultural competence training in Lancashire. And it parallels the sort of components of a patient navigation intervention. We carried out a comprehensive evaluation of this intervention to understand its effectiveness on addressing inequalities, but we also wanted to look at whether it's equitable, who benefits from it, and how it can be improved. And our sort of findings show that Colfricate is quite effective to improve participation, about 15% among non-responders of screening. But we found that they had no impact by age, gender, or deprivation. It had an impact on ethnic minority groups specifically, and mostly among people with disabilities. When we looked at whether it's equitable, we identified that only 1 in 2 non-responders are reached through this approach. And the target population, for instance, the first-time screeners, non-responders of the screening program, they often do not pick up their phone call, which is the approach delivery method used to reach the target population. But once people are reached, the acceptance of this program is very high at 80%, and about 97% of the people who attend the clinics are actually requesting a test kit to complete it afterwards. Our qualitative evaluation demonstrated that the program is very effective to target barriers such as not knowing awareness about bowel cancer screening, why they should be taking part in screening. It provides instructions on how to perform the behavior, and also gives people's reassurance about the screening outcomes with information about potential consequences. But one of the key elements of this program was that bringing people back to the healthcare system, because obviously the bowel cancer screening is out of the healthcare system, takes place at home, the behavior happens at home. So bringing back to the GP practices and that proactive approach was very valued. And people felt like, oh, I'm doing something about my health, and my GP is inviting me to come and help me about this, making a decision about screening. And that personalised approach and tailoring the screening health promotion programme to the people's needs was very effective. And so what I kind of want to say is, well, while we identified that it is very effective improving inequalities, obviously that there's areas of improvement such as improving the reach at first stage. But in summary, community organisations for targeting hard-to-reach populations is the best method to address place-based inequalities using tailored approaches. But we need to integrate more behavioural science and implementation science, as well as co-design, to understand who benefits from these interventions and how we can also reach most marginalised communities. Thank you very much.
Thank you very much, Yaz. Thank you so much for that. And again, if you have questions for Yaz, do please put them into the question and answer segment. Now, our final panelist is Meta Glass from Europa Colon in Slovenia. And Meta's topic is effective campaigns for increasing awareness and reducing stigma. Meta, looking forward to hearing your views. Over to you now. Thank you.
Yeah, thank you, Karen, and thank you all. I would like to address that I was a caregiver to my father who lost his battle of the colon rectal cancer 16 years ago. So I'm not going to talk from the medical perspective, but from a perspective of a human being. And that's why I would like to tailor my, let's say, 3.5 minutes into the point what Simon Sinek once said, and that's the golden circle. So why we do what we do. In this case, we need to ask, what's in it for me that certain people will react and will respond, It's not just about the life, it's about that our dreams, our plans are actually disappearing in a second. And it's not only about our individual plans, but the plans of the whole family and communities. When we address that, then the next question is, how are we going to do it? Who do we trust? As Zorana mentioned already, the trust. Who do we trust the most? And in this case, in Slovenia, we have researchers that among the most trusted associations are the firefighters. And Slovene Firefighting Association has been supporters of the SWEET program. So every country can ask, who do people trust the most? Because they will come to them to gain the information. We know that the importance of word of mouth, it's very high. And then the next thing is, of course, who do we trust? We trust our families, our family members. But to be able to really start this discussion, we have to break down the stigma. I can tell that even, 20 years ago, when the whole situation with my father started, we did not talk about that openly inside the family. And we are all well educated. And this is happening still. And I'm coming from the culture which is very open in many cases. So we need to really start the communication also on how, what kind of language and forming this very safe physical environment inside the family, among the peers, among the close friends, because men will talk to men. And here we see that also, let's say, the results, but I don't like to put the figures because it's about the stories of people. Yeah. For me, the figures are not that important. I don't have my father here, and that's the most important part. But the 11% point lower rate is among men than women. And it's interesting things that in Slovenia, those men who have partners, those men are getting to the screening programs much more than those who are living alone. So we need to find who do they trust the most. Another thing is also, when we go from how we do it is also the language. I'm not let's say, we need to find a way how we talk very difficult things in very simple way, in a way with full of empathy. For instance, just yesterday, when I was preparing for this, I was searching for a video about poop, how kids are pooping, because my daughter, she's 7, she has problems with that. And it's interesting, we don't have issues when we discuss this with kids. However, as one of our patients told us in the patient support groups, which we are running in Europa Colon Association for younger patients, she said, how should I know that my stool it's not normal? Nobody discussed that with me. Nobody told me. Even GP practitioner, he never asked, what kind of stool you have. And we don't want to talk about that because we're embarrassed. So there is still a lot of fear. And when we talk about the trust, of course, health practitioners are there. But we need to talk not health practitioner to the patient, but human to human. Because in that case, we can lower down the fear of the unknown, the fear of the colonoscopy as something that it's still very painful, the fear that, oh, if I get screening and the test is positive, oh, this is cancer. No. So we need to really start talking human to human and actually improving in this case. So what else we could say? Yeah, Patients Association, as we are doing a lot in terms of educating people, but this is like, step-by-step approach. So we need to start this education far more than from 40 years of age, but earlier in schools and then moving on further. So I would say that trust, collaboration, also not just beyond, who we are here, but also to include media, to include others who these groups really trust, and being also patient and building the storytelling approach is the way. What's also important, and this is my end, is that in Slovenia we use ambassadors, and they have the powerful voice among those who are going to screening programs, because they tell their own stories in their own ways. They also educate others, and it's always like, men tell the stories to men in their surroundings, women tell the stories to women. So there is still a lot to do, but really to make it more pleasant. And also how one man said, well, if I take my car, for a service every year or every time, when a light comes on, let's think about, what are our lights in our bodies and do the body checks on ourselves. So that's from my side.
Very good, Metka. Very, very interesting. I actually, we have some questions in already, but maybe we could start the ball rolling. I want to put a question to you. You made several very, very interesting, poignant points to make, including one that your father didn't want to talk about his situation. Before I ask you about that, because the communication of what's wrong with our bodies is obviously can be a very sensitive thing. Tell me a little bit more about the poop situation, because it is a very embarrassing thing, isn't it? You know, to go into, we'll say, your GP and to have to say you have a problem with your poo. I mean, it's not something we feel comfortable with, is it? It's something that's very personal. How do you get around that and enable people, whether they're men or women, to not feel embarrassed about these things?
Well, actually, this is something that we will still need to figure it out, but this was the comment from a month ago from a patient. You know, she's 42, and she said, you know, today I had to talk with my boss because after 7 months, I'm getting back to work. Thank God she was on time, you know. And she said, how should I talk about, you know, my stool with my boss? Because sometimes I could still stay, you know, for an hour or two and I might be late to work. Should I not even mention it? But then she said, look, you know, I need to mention it. I need to start talking about that. And she told us everything was fine. I was so afraid because he's a man, you know, I was so afraid. And he said, no, let's do even more inside of our, let's say, work office, you know, tell us more about it. We should know more about that. Yeah. So I was thinking about, I don't know how it is in your country, but in our country, the stand-up comedy are very, very popular. And 90% of the stand-up comedians are men. Yeah. So I was thinking, you know, they should do something as an act because it has to go viral. They have to start talking about it. So poop is something, it's a beautiful word. It's not like a shit. Yeah. Trying to figure out something that will bring us close to our heart and that we can smile. Yeah. So this is something we will try to make it happen already next year.
I love that. Poo isn't shit. And just very quickly, your father was, you said, am I right in saying he felt very uncomfortable talking about his disease, which was colon cancer?
And he was the professor at the Faculty of Economics. So he had to go out, you know, during the presenting for 3 hours because he had some obvious reasons, you know. He didn't even talk with me about that, you know, because he felt so embarrassed. So this is something which is very stigmatized, you know, and we're all very well educated. Yeah, we're very open-minded. So we have to find a way, you know, how to already start building in the education that this is normal, you know. Actually, yesterday I was discussing with my daughter. So, Lara, you know, do you need to go to poop? Yeah, mommy, you know, my poop is like that, you know, is that okay? Yeah, it's okay. So to make it more playable, you know, this is not stigma, you know, this shouldn't be a fear. It's about life. It's about life.
Yes, and obviously incredibly important to be able to understand to talk about your poo if something is wrong, if there are changes, because these could be indications. I'm not a medic, but am I right in saying then these could be indications that something is wrong? So it's very important that you are able to talk freely about these things. Okay, do any of our panelists now, we have all our lineup, all female panel this morning for our final one. Lovely to see. So we've got Zorana again, Isabel, Yaz and Metka all joining me again. Anthony Rossi has put a question in. All-right population screening was introduced in a lot of countries in Europe. Now, what is the next step? Just put your hand up, or yes, Zorana, you can take that question. Thank you.
Actually, I have put my hand up because I wanted to follow up on what Metka said, because I had a similar issue within my family. I was at a TV talking about colorectal cancer, importance of early diagnosis and screening. And when a family member called me and told me, you know, you did a wonderful job, you explained it so well in a very simple language. Yet a couple of months later, I have realized that that particular family member has been struggling and had issues with their poo for the last 2 years, underwent colonoscopy, and some very big polyps were found. Luckily, everything went well. But what I want to say is that this is something that even, you know, us, that we are doing this all the time. We are talking about this all the time, but even people in our little circles, you know, they are reluctant when it comes to poo, when it comes to colonoscopy. Then when I ask, you know, so what's the reason? You know, you said I explained it beautifully. What didn't I explain well? And the answer was, I was too afraid to undergo colonoscopy. I was too afraid to find out that I might have cancer. Later, you know, luckily, this family member realized that, you know, it's not cancer, it's precancerous lesion, and everything is okay. But can you imagine how many people are out there that do not undergo this test, or ignore symptoms, or do not go for screening because they believe that everything is okay? So this is what I wanted to say on Metka's point. And then when it comes to Anthony's question, frankly speaking, I'm not sure I understand what all right population means. I don't know if some other speaker wants to comment, or if Anthony wants to clarify the question.
Yes. And maybe Anthony, you can clarify the question if you're still with us. But yes, you wanted to maybe comment on Anthony's point.
Yeah, so if I'm understanding right, that a lot of the countries are now introducing population-based screening programs, and I'm guessing the next step is in the context of this topic is how to address inequalities. That's what I'm thinking, but I can talk about in the context of English screening program. There is a lot of emphasis now when moving towards what we talked earlier about, from one-size-fits-all approaches, which is the sort of equal opportunity approaches. It has to be sort of standardized in a screening program or organized screening programs. But we have a lot of move towards tailored approaches or targeting people based on their inequalities. So all inequalities, all screening programs in the UK have this health equality assessment now embedded, and that's carried out, I think, annually at least, to identify who needs more support. Also, for instance, having reasonable adjustments requests in different languages, as we talked about, but not just in languages, also making it more accessible for the right people for the right time. And that's more at local area level rather than at a system sort of top-down level. So I think bringing the gap between that local areas, addressing place-based inequalities with this sort of more top-level system-based approach is the important one, and then improving the communication between the local areas and the decision makers.
Anthony, and thank you for doing that, Anthony. And Isabel, I'll go to you now as well. Anthony has clarified it's the FIT program, actually. Yes, this is the kit you were talking about, is it? That's sent to people. Yeah. Can I just ask you, before I go to Isabel, in terms of communications, how do people know? Because you mentioned it was being rolled out in the UK, and I know it's being rolled out in Ireland as well, because I actually volunteered to do one myself. How do people find out or know that this kit is available for them in the UK, for example?
Obviously, it's kind of advertised. We have lots of social media campaigns to raise awareness. But the main thing is that when you reach your in the past, it's 60th birthday. Now it's majority of the places, they're all out down to 54, 52 years old. So when someone gets to their 52nd birthday, they'll get a pre-notification letter from the screening program. If they have a registered GP address at their GP practice, then they will get a letter saying you're about to receive a screening test kit.
Yeah, okay. Isabel, you wanted to, I think, comment on the same question that Anthony had put in through the chat box.
Yes, because I was understanding that so there is the fit screening extended in many countries, but is it working correctly in all of them? So we need to understand if it's not working correctly, what we need to do, and building on what Yasmin mentioned initially about the implementation science. So you have this opportunity to understand what is the problem at these different steps, asking obviously the population what is the issue making them not access screening. For example, it maybe the invitation is not well understood. It may be that instead of getting the kit home, you have to go to a pharmacy to pick it up. So that's already an issue on accessibility. Then you don't know where you have to give it in, you know. There's a lot of barriers that you can face that if you don't speak with the population, you don't understand. So that would be the thing I would like to comment on that sense, and it builds upon on what has been mentioned before. We need to understand the how, not only what, we know what is the fit screening, but how we are going to actually implement this.
And also, because I know this just from personal experience using it, I wasn't sure whether I was using it correctly. I mean, is there an element of a need to communicate that message to people as well, to be very clear about how to use these things?
Yes, and it would be important to have a population actually participating in designing those instructions if they are not clear. I know not for specifically for fit tests, but for self-sampling and with HPV, this has been doing in some countries, having women working together with researchers on improving the content of the invitation and the instructions. So this could be thought of if it's an issue in the country, if we identify this as an issue in the country.
And Isabel, and it touches on a point Sorana has made earlier, you gave all those statements from people in your presentation, which was very interesting, all the reasons why they mightn't get tested or they don't want to get tested. Or like Sorana has been saying, maybe people don't want to get a scope done in case they're told they have cancer. So how do you get around all of those phobias or fears that people have and just encourage them to go and get the testing?
Well, I guess for this we need what also Yasmin was mentioning before, behavioral science, to understand what can make people change this behavior, understand, as I was showing you before, this process of being unaware of screening and engaged and then deciding to participate. We need to understand from the behavioral science how we can actually tailor this message so that population can understand it and decide to participate, have at least the information to decide whether or not to participate.
Okay, we have a question in from Natasha Antolyak, and she says, in Croatia, we are faced with a lack of MD working as GPs, so they declare they like to participate in CRC screening programs, but in fact, they do not have the time to do this, or just one part of them can and like to do it. Excuse me. Do other colleagues have similar problems with lack of GPs, which can affect CRC screening responses rate due to lack of communication with people? We know that from many countries, agencies search for our medical doctors and nurses, for example, from Ireland, Norway, or Germany. Now, I don't know whether that question is applicable to any of you, but raise your hand if it is something you feel you can comment on. Yes, Metka, and then I'll go to you, Sorana.
Yeah, we have very similar situation with GPs and pediatricians in Slovenia. So we are looking them all over, let's say, Eastern Europe. Yeah. So a lot of patients lost, GPs in the last 3 to 4 years. And especially the evidence has been seen, also because of the COVID crisis, where they could not actually come to the GPs, how to explain everything through the phone or how to explain everything in emails or something like that. And that's why, for instance, this is the whole systemic strategy. You know, we cannot find, but what we can do, the patients' organizations. So we started this year with monthly professional webinars, which are free of charge, which were mostly, you know, focused on the patients and caregivers. But interestingly, that 1/3 of participants are from the healthcare practitioners, nurses. So what is going to be the next step is, you know, that we're going to try to establish in the first quarter of next year kind of a, let's say, working group with the primary, with GPs, and also with the tertiary, you know, from the oncologists, you know, and include the patients and caregivers inside of that. So association is going to be kind of a bridge, yeah, so that we start discussing that, because mostly the problem is with younger patients, because they are not getting heard. They are not getting listened to, you know, when they have issues, you know. They have to be really, you know, proactive. And sometimes, you know, they are saying that they have hormone problems or something like that. So this is something what we would like also to address more, to be kind of a bridge among all of the key stakeholders.
Okay, and Zorana, you wanted to talk as well on this?
Yes, I just want to briefly mention some of the discussions that we had as the part of the working group of the European Colorectal Cancer Initiative. You know, involving GPs is not ideal in a sense that it's more costly. And also I will go back to the point that I believe Professor Marcis Leia and some of the panelists in the first panel mentioned, that it doesn't work in Latvia, for example. So for Croatia, I understand the situation is not unique just to them. I believe once the new updated guidelines are issued, maybe they should adapt the strategy and change the way of inviting citizens to the screening program.
And Zorana, awareness campaigns are really a key backbone of DiCE. What's your vision in terms of those kinds of campaigns and the strategies that you want to embrace in terms of communicating messages?
Well, I believe, thank you for the question. This is really what we do at DiCE during the whole year for all digestive cancers, with the key focus on colorectal cancer because of the screening programs. And I feel that it's really important to understand the target population. And as Isabel said and also Yasmin mentioned during her intervention, it's really important to understand what are the barriers, what are the motivators, and then to tailor the campaign. Obviously, there will be never one campaign that would fit all sizes. But you have to adapt it. And for example, I will mention that for gastric cancer screening, for the project, TOGAS project that we're doing, we did a big survey of the general population to understand the barriers and the motivators to undergo gastric cancer screening. So I think it's understanding the populations, the motivators and the barriers, and then designing the campaign. And then once somebody said, do you know what's the best campaign? Obviously, I said no, and they said the one that is executed. And I think it's simply important, you know, just to keep on repeating those messages from one year to the other constantly, because we have to educate general population and citizens about the importance of early cancer diagnosis for all cancer types.
And I presume the media plays a huge role and getting the media involved. I mean, I know in my own country, in Ireland, radio is incredibly popular. I mean, television is obviously very powerful, but millions of people in the country turn on their radios every day. And for example, more recently, women have come out and started talking about the menopause, which was something that just wasn't discussed on the airwaves. So how important do you think is it to engage with the media to make sure that they're helping in enabling people to talk about these things and to go and get checks if they need to?
It's very important, yet it's often very difficult or costly. Especially, I would say, when it comes to colorectal cancer and digestive cancers, it's much easier to talk about breast cancer. Females are more open to talk about their health, but that doesn't mean that this will discourage us. We see this as the opportunity. We use alternative ways. We use social media, but yet we have to design the right strategies for the right population, meaning that radio, television, written media, this is something that I believe that the screening target population for colorectal cancer is using most. So yeah, we have to work all together. And I am a big advocate of the awareness campaigns being done jointly with the government, with the Minister of Health, because together with the screening programs, because this is the most effective way.
And Isabel, if I can go to you, can you talk to us a little bit more about how the IARC is engaging with communities in decision-making processes about screening?
Yes, so we are working, as I was presenting before you, the barriers to cancer screening. We are working with countries in helping them identify barriers across the cancer care pathway. So when our main point of contact are ministries of health, but we actively make them involve communities to participate in this discussion, which are the priority barriers to know what should be the next step. And we're also involved in implementation research projects, and this is what we were talking about before, this how do we do things. So we have we involve communities in the discussion of which barriers they are facing in this screening program, which facilitators they see to actually make population participate more. And then we will work with them tailoring this intervention, these strategies to suit this. And this is what we are testing in several projects. And also, obviously, there's a huge involvement in the communication and dissemination part. This is a strong point for the groups also. That would be our...
Okay, and do you find it challenging to engage with different communities, or do you find generally there is enthusiasm about engaging in these things?
I find this enthusiasm about this. They want to be heard. And I think this is
important.
Want
to be heard, yeah.
Yes, because I was saying before, the traditionally has been this one-way direction of informing, and now we are getting to involving more, engaging more, and I think this is they are feeling like happy to participate and to be heard, listened to.
And yes, I'll just go back to you maybe for a final question, because you mentioned about, the different communities that are out there, and we've heard this a lot over the course of the morning, even starting, I think, from Iris's presentation at the very beginning about people from communities. For example, I think Turkey was one of the countries she mentioned in the presentation, that it's harder maybe for these people to come forward for screening programs or to reach them. The UK is a very multicultural country with lots of different cultures. So what innovative methods is your organization or those involved with you engaged in to try to target these more harder to reach communities?
Yeah, thank you for that question. I think that's a very interesting one. So I suppose it kind of goes back to identifying the sort of facilitators of the behaviors and using behavioral science a bit better, and understanding who would actually listen to the radio, who would actually look at social media content, and can we use those different sort of delivery methods to innovate better. And but the pharmacies, another one, who goes to the pharmacies, who goes to their pharmacists to talk about about their health, and it is sort of the stigmatizing or demystifying sort of the barriers people think about when they think about bowel cancer, sort of can we demystify bowel cancer, or the poo or the stool? Can we empower mothers because we talk about poo from the moment that a child is born, that's a sort of a sign of health. Mothers look at the poo to understand whether baby is healthy. So I suppose innovation comes from communities, and core design is a very important element of it, and targeting communities to identify the best methods. And I think that's how we're going to innovate, grassroots innovation, designing the interventions with the people. And it could be the text messages, it could be AI, but how do you actually using these in the best way to benefit to people who would actually benefit from those, if that makes sense. And it could be social media campaigns, but we need to also integrate evidence-based approaches to evaluate those things better, to understand, does it actually make an impact on cancer outcomes?
Metka, do you have any final views on that, how to reach hard to get members of communities and populations?
Well, just to be human, and just, start talking from the heart, because no matter who we are from the professional side, we're all human beings. And when we will find that door, or when we will open that window, even if it's tiny, that's what's going to bring success.
Well, on that very optimistic note, we'll leave it. But Metka, Zorana, Isabel and Yasmin, thank you so much for your fabulous contribution. That was great. I will say goodbye to you. Thanks to those of you who submitted questions during this particular session. We're coming to the final part of our panel, of the whole summit actually. So panelists, I will say goodbye to you. And now I want to introduce Mariana Vitelloni. Mariana is a medical and scientific project manager with Digestive Cancers Europe, and she's a patient advocate. And at DiCE, she coordinates medical and scientific initiatives using her multidisciplinary experience to build the bridge between science and global health. So Mariana is going to discuss now the role of patient organizations and citizen groups in shaping the way forward. Mariana, you're very welcome. I'll hand over to you now. Thank you.
Thank you, Karen. Good morning, everyone. As we wrap up the 5th DiCE Colorectal Cancer Screening Summit, I want to thank you all for taking your time to join us and share your knowledge. Your dedication to improving colorectal cancer screening across Europe is inspiring, and it makes this summit a valuable space for collaboration. This year's summit focused on an important goal: achieving 90% colorectal cancer screening coverage across Europe by 2025. This goal is ambitious but unnecessary, and today's discussions show how powerful collective action can be in reaching it. Throughout the day, we cover key topics for scaling up colorectal cancer screening programs. Policy and advocacy, we look at how EU recommendation can guide national strategies and the need for policies that address differences between countries. We talk about personalized screening. We talk about innovative ways to tailor screening based on risk factors like age, sex, and lifestyle, making programs more effective and fair. Public awareness and mobilization. We heard about successful strategies for engaging communities, reducing stigma, and using public health campaigns to encourage screening. The ideas shared today highlight both the challenges and the opportunities ahead. While achieving our goal will take efforts, the knowledge and strategy we have discussed provide a strong starting point.